Hello, everyone, and welcome to today's symposium, the 4th Annual Re-envisioning Elder Care Conference. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation using your computer speaker system by default for audio. If you are having difficulty hearing us, please use an Ethernet connection or move to an area with stronger Wi-Fi. Shutting down other applications on your device will also open up more bandwidth. You will also have the opportunity to submit your questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your typed questions at any time during the presentation, and we will collect these and address them during the Q&A sessions throughout today's event. Today's webinar is being recorded. And with that, I would now like to introduce Dr. Nashira Pandya, Professor and Chair of Nova Southeastern University's Kiran Patel College of Osteopathic Medicine, Department of Geriatrics, and Project Director of the NSU South Florida GWEP. Dr. Pandya, over to you.
Okay. Let me get my camera on. Okay, thank you so much, Clara, and good morning, everyone. I'm really delighted to welcome you all to our 4th Annual Re-envisioning Elder Care Conference. A special welcome to our students, residents, fellows, our community partners, and subject matter experts. We're so excited to continue our partnership with the GWEP at Florida State University called REACH, as you see on your screen. And I really want to thank the planning committee for their initiative, their vision, and dedication in organizing an event, which we hope will raise the bar in elder care and continue to inspire us. I've been thinking a lot about our journey together since 2019 with this series of conferences. We began with renewed energy to educate healthcare professionals and to enhance our practices in adopting the age-friendly healthcare model back in 2019. Then we went into the pandemic years, and now we're probably in the endemic years, where we were deep in a serious healthcare emergency. We continue to promote age-friendly healthcare in a COVID-19 world. We explored the importance of ethics, telehealth, technology use, and reimagined what assisted living and nursing homes could be, and what good medical care should look like, even in the state of emergency. In 2023, we've learned many lessons from our patients, our colleagues, our state and national organizations. We've also lost many beloved patients, colleagues, and healthcare professionals. And to some extent, I think we've lost our innocence. Today, we still have the urgent need to educate healthcare professionals and health profession students in geriatrics. We need to improve dementia care, to learn to incorporate technology, telehealth, and now artificial intelligence, and to improve nursing home care. We need to renew our focus on resiliency, staffing, and to reduce burnout. I want to thank the Health Resources Services Administration for funding our 2 projects. And I want to welcome you, and let's get started. I also want to let the participants know that none of the presenters has any financial conflicts of interest in their presentations. So thank you so much. And we'll get on with the first presentation. So good morning again. I'm going to introduce Dr. Joseph Mylott, who is doing the first presentation. He received his medicine degree from the University of Medicine from the School of Medicine at the University of Buffalo in 1973. He's an internist and an infectious disease specialist and a professor at the School of Medicine. He retired in 2010, but continues to be very active. In terms of geriatric experience, Dr. Mylott served as an attending physician in the acute geriatric service at Erie County Medical Center in Buffalo, and he was director of this unit from 2000 to 2005. In addition, he was an attending physician and medical director for several nursing homes in Western New York, primarily doing post-acute care. His research interests in the past 20 years have focused on the study of nursing home pneumonia, which still continues to be so important, antibiotic use in long-term care, and C. difficile infection in long-term care. He's a fellow of the Infectious Disease Society of America, Society for Healthcare Epidemiology of America, and the American College of Physicians. He retired from practicing medicine in 2015. Please join me in welcoming Dr. Mylott, who will be presenting Determining Appropriateness of Initiating Antibiotic Therapy in Nursing Home Residents. So welcome, Dr. Mylott, and please proceed.
Thank you. Appreciate that kind introduction. Before we go on, I want to go back and note that I have no conflicts of interest or financial disclosures. I would like to take a moment to just thank Dr. Paul Katz for his encouragement in developing this topic I'm going to discuss today, and also assistance in a manuscript regarding this topic that has been published online at the JAMDA website. I'm going to start with two poll questions for the people listening in today. The first one is, do you presently work part-time or full-time in nursing homes setting? And we're talking about physicians, nurse practitioners, PAs, social workers, administrators, DONs, ADONs, social workers, pharmacists, and so forth. Yes or no? This is just to get some indication of those of you who are spending time in the nursing home setting. Okay, thank you very much. We'll go on to the next question, which is, for those of you working in the nursing home setting, does your facility have an antimicrobial stewardship program? Yes, no, or you don't know. All right, very good. Thank you very much. Let's proceed. All right, I want to start with the rationale for evaluating appropriateness of antibiotic therapy in nursing home residents. Many of you have seen this information previously. I'm just going to review it quickly. Upwards of 70% of nursing home residents receive at least one course of antibiotics yearly. Of those that receive an antibiotic, it's been estimated that at least or as many as 75% of those prescriptions are inappropriate. The collateral damage from inappropriate therapy is listed on the bottom, and that is adverse drug reactions, C. difficile infection, and the development of resistance. Of those three, C. difficile infection is the most important. A little bit of background regarding antimicrobial stewardship programs in long-term care. As you know, CMS in its revision of the conditions of participation for nursing homes requires that long-term care facilities have a stewardship program that includes monitoring for antibiotic use. At the same time, the CDC, to assist nursing homes in following that condition of participation, developed core elements of antimicrobial stewardship, one component of that being identifying inappropriate use of antibiotic therapy. However, determining appropriateness of initiating antibiotic therapy has been a major challenge. An example of this challenge is identifying residents with urinary tract infection. That's resulted in the publication of multiple decision tools for the diagnosis and treatment of this infection in the past 2 decades. I reviewed this topic 2 years ago. I want to start with a clinical vignette to set the stage for the rest of the discussion. We have a medical director of a skilled nursing facility who's the chairperson of the stewardship program at that facility. The team includes infection preventionist, a pharmacist, a facility physician, and 2 staff nurses. The program evaluates appropriateness of therapy for 3 infections: urinary tract infection, pneumonia, and soft tissue infection. The team utilizes the revised McGeer criteria for evaluating appropriateness. And I'll get into a little bit of detail about that particular criteria shortly. They collected data for 12 months, and they found that the range of the monthly rate of appropriateness of initiating treatment for each infection varied, as listed here, and was actually low for all 3 infections. This was of concern to the stewardship team, and they decided after some discussion to change to using the Loeb criteria for evaluating appropriateness. And again, I'll come back to an explanation of the Loeb criteria shortly. They collected data for 6 months using the Loeb criteria, and again, they found the same low rate of appropriateness for each infection and monthly variability. So with 2 different criteria, they found low rates of appropriateness of initiating antibiotic therapy. The team was concerned about the validity of the findings, and they didn't feel that their practitioners were prescribing inappropriately to that low level. In order to try to deal with this in more detail, they set about deciding on a series of questions that they needed to ask to try to better understand the use of the McGeer and Loeb criteria. And they looked at the following questions, 5 of them. How were the revised McGeer and Loeb criteria developed? Are there studies that utilize these criteria for evaluating appropriateness? What are the limitations of these criteria for determining appropriateness? Are there alternative methods for assessing appropriateness? And besides the process of initiating therapy, are there other elements of the prescribing process that need to be considered when assessing appropriateness? So we're going to go through each of these questions. So first, how are the revised McGeer and Loeb criteria developed? We have to go back to around the late 1980s and realize that at that time, there were no standardized surveillance definitions for infection in the nursing home setting that would allow for monitoring infection rates that could be used to compare rates among facilities. So in 1989, Dr. Alison McGeer at the University of Toronto convened a group of experts interested in this problem, and by consensus, they developed surveillance definitions for infection that were published in 1991. And these have been referred to as the McGeer criteria. These criteria were accepted as the standard for the surveillance of infection in nursing homes by APIC and SHEA, the 2 major societies interested in this problem. These criteria were also accepted as the standard for the diagnosis and treatment of infection by the Department of Health and Human Services and CMS. The development of the revised McGeer criteria began in 2009 under the leadership of Dr. Namali Stone from CDC, in conjunction with a group called the SHEA Long-Term Care Special Interest Group. They undertook a revision of the McGeer criteria that was published in 2012. Full transparencies, I participated in this revision. The only major changes were the definitions for pneumonia and urinary tract infection. Now, I want to make a statement here now that's going to be important as we move along in this discussion. In that 2012 paper, there's specifically a statement that warns against using surveillance definitions to determine when it's appropriate to initiate antibiotic therapy in a resident. It's 3 sentences in this pretty long paper. Here are the 3 sentences. The criteria that define infections for surveillance were selected to increase the likelihood that the events captured by the application of the definitions are true infections. In other words, surveillance definitions are created to be highly specific to minimize the risk of false positives. Presentations of infection in older residents may be atypical, so failure to meet definitions may not fully exclude the presence of infection. Because of this, the surveillance definitions presented may not be adequate for real-time case finding, diagnosis, or clinical decision-making. For example, initiating antibiotic therapy. So this is a critical statement that's buried in this long paper, of which probably nobody has read before. And I wanted to point this out because it's important as we complete this discussion today. All right, so the development of the Loeb criteria. In 2000, members of SHEA with an interest in infections in nursing homes, led by Mark Loeb at the university at McMaster University, developed minimum criteria for initiating antibiotic treatment in residents, referred to as the Loeb criteria or Loeb minimum criteria. Again, full disclosure, I participated in the development of the Loeb criteria. The rationale was to try to deal with the overuse of antibiotics by providing a method for practitioners to decide when to prescribe antibiotics. It was hypothesized that minimum criteria were utilized in practice, there would be a reduction in inappropriate antibiotic use and possibly a reduction in the risk for developing antibiotic resistance. So in summary, surveillance definitions, such as the revised McGeer criteria, were not designed to be used to assess appropriateness of antibiotic therapy. On the other hand, the Loeb criteria were specifically designed for this purpose, to assist physicians in making these decisions to start antibiotic therapy. The next question is, are there published studies that have utilized these criteria to evaluate appropriateness? So a literature review was done using Google Scholar and Medline with Ovid between January 1992 to March of 2022. And the review identified 21 studies published in English that utilized either the McGeer criteria, the revised McGeer criteria, or Loeb criteria to evaluate appropriateness. And the breakdown of the various studies is listed here. I can't give you the details of the review because of time limitations, and I'm going to just summarize the findings very quickly. Regardless of the criteria utilized, rates of appropriateness were low, and there was considerable variability in the level of appropriateness of initiating therapy by type of infection for each criteria. And I'll show you a little bit of data on that on the next slide. The methodology of these studies varied. Some were done prospectively, some were done retrospectively. There was a variation in how the study population was identified and variation in the size of the study population. A good example of the variation in how the study population was identified is exemplified by studies of urinary tract infection. And I've just listed here how a study population was identified. So some used identification of infection by an infection control nurse. Some use residents with a positive urinalysis, suspected infection by a nursing staff member, residents who had a urine culture done, or infection logs that indicated treatment for a urinary tract infection. So considerable variation in that factor. This is taken directly from the paper. This is a table in the paper. And the data here being presented is the percent appropriateness of initiating antibiotic therapy for each of the 3 infections by each of the 3 criteria. And of course, urinary tract infection was evaluated most commonly, pneumonia rarely, and in between skin and soft tissue infection. Let's look at the urinary tract infection as a good example of the variation. The McGeer, in 3 studies using the McGeer criteria, the variation was 15 to 51% appropriateness. Revised McGeer criteria for 5 studies, 13 to 32%. And in 9 studies using the Loeb criteria, 8 to 44%. So considerable variability for each of the 3 criteria for urinary tract infection. There's too few studies for pneumonia to make much out of it, but you can see the variability there. And skin and soft tissue, there was less variability using the Loeb criteria, but still wide differences among these studies. So are there limitations of these criteria for evaluating appropriateness? See if all right. So surveillance definitions should not be utilized to determine appropriateness of antibiotic therapy. That's a major limitation of using the McGeer or revised McGeer criteria. The Loeb criteria requires signs and symptoms that are localized to the infection site. And this impacts the use of the criteria due to the fact that many times there's a lack of documentation of signs and symptoms, especially if the evaluation is being done retrospectively. And residents with cognitive impairment may not be able to provide an accurate history. So this is a shortcoming of the Loeb criteria. They particularly exclude non-localizing signs and symptoms because of low specificity. The other issue is it's unclear the extent to which practitioners in nursing homes utilize the Loeb criteria for prescribing antibiotics. There's actually some indication that it's used very little by practitioners. Are there alternative approaches to the McGeer, revised McGeer, and Loeb criteria for assessing appropriateness? And the answer to that is yes. There's multiple alternatives. As I mentioned before, the Loeb criteria, as well as the revised McGeer criteria, rely almost exclusively on the presence of localizing signs and symptoms, localized to the site of infection. As I already said, the chart documentation of these signs and symptoms leaves something to be desired, and also trying to get a history from a cognitively impaired resident is difficult and does not really provide an accurate history of symptoms and signs in many situations. In the absence of documentation of localizing signs and symptoms, clinicians prescribe antibiotics based frequently only on the presence of non-localizing signs and symptoms, such as acute change in mental status, occurrence of a fall, decreased appetite, acute change in functional status, or fever. This has been a particular problem in the diagnosis of urinary tract infection, not only in nursing homes, but in the emergency department of hospitals when you send a resident in to be evaluated. All right, so this has led to a consideration for including non-localizing signs and symptoms and criteria for initiating antibiotic therapy or use in clinical diagnosis of infection. So in 2013, it was suggested that non-localizing signs and symptoms be considered for inclusion and criteria for initiating antibiotic therapy in residents. This was in a paper by Drs. Rowe and Juthani Mehta in 2013. However, this particular idea didn't take hold at all, as far as I can tell. However, because of the long-standing dogma that an acute change in mental status is an atypical manifestation of urinary tract infection, there's been a focus on the association of delirium with urinary tract infection. There have been 3 systematic reviews evaluating the association between delirium and UTI in the elderly. And these 3 particular reviews have come up with contradictory results. And I've just listed the references here. Non-localizing signs and symptoms as part of infection surveillance definitions. Post hoc study of data collected as part of a prevalence survey of infections in 161 nursing homes in the US used the revised McGeer criteria to identify infection. And they added to it a modification of the confusion assessment method that all of you are aware of to define an acute change in mental status in order to identify infection. So they compared the revised criteria alone to the revised criteria plus the modified CAM. And what they found was that when the modified CAM was added to the revised McGeer criteria, the number of infections identified increased by about 12% compared to using the revised McGeer criteria alone. The other issue is, can non-localizing signs and symptoms be clinical predictors of infection in residents? So a recent review evaluated the role of non-localizing signs and symptoms as clinical predictors of infection in residents. This is a relatively recent paper by Teresa Rowe and her colleagues. The non-localizing symptoms and signs identified as potential indicators of infection were fever, hypothermia, hypotension, new onset hyperglycemia, and delirium. The authors of this review stated that the findings will be used as the foundation for an update to the Loeb minimum criteria. Now, as an aside, I was at a meeting in 2019 of a committee at one of the infectious disease meetings, and this came up that there was going to be a revision of the Loeb criteria. This is 2019, October. As far as I know, the revision has not been published. I tried to get information from some other colleagues regarding the status of this revision, but was unsuccessful up to the present time. All right, so there are other algorithms that have been published to identify infections in residents using non-localizing signs and symptoms. So an algorithm to evaluate the appropriateness of initiating antibiotic treatment for suspected UTI in residents included an option to initiate treatment in the absence of localizing signs and symptoms of UTI if there's a change in status associated with one or more warning signs. The warning signs were fever, rigors, delirium, or unstable vital signs. This algorithm was developed by Chris Cernich and Paul Drinka at the University of Wisconsin and published actually in 2014. The algorithm, turns out, it was included as part of a toolkit to improve the diagnosis and treatment of UTI in nursing home residents, published in 2019. As far as I can tell from reviewing the literature, there have been no publications that have used this toolkit to see how well this algorithm functions. Another algorithm or guideline was developed in the United Kingdom, in which guidelines for the identification of UTI, lower respiratory tract infection, and skin and soft tissue infection in residents modified the Loeb criteria such that non-specific signs and symptoms by themselves could initiate an evaluation for infection. Again, recently published, I could not find any further study of these guidelines to see how well this modification identified the need to initiate antibiotic therapy. There have been many other efforts to help clinicians identify infection in nursing home residents. Several medical societies, the Infectious Disease Society of America, AMDA, has published 2 different guidelines to assist in identifying infections. AHRQ, the Agency for Healthcare Research and Quality, has developed a really extensive toolkit for determining when to treat for infection. And various states have developed also guidelines or tools for this purpose. I've just listed the one for Minnesota on the slide. So there are a variety of different efforts to enhance the ability to identify infection and to help identify when antibiotics need to be started in nursing home residents. In addition to initiating antibiotic therapy, are there elements of the prescribing process that need to be considered when assessing the appropriateness of antibiotic therapy in nursing home residents? Here's, on this slide, I've listed what I feel are the important components of the prescribing process. We've been talking about decision to treat, but after that decision is made to treat a person with an antibiotic, then you have to choose the antibiotic. You may want to consider changing the dose in an elderly population for some drugs. And then a factor that you may not have considered is what's referred to as the antibiotic timeout protocol. So after 2 to 3 days of treatment, you assess the response, you review any laboratory data or imaging that is available, and based on that information, you decide to continue the therapy that's been prescribed. You may change to a more broad or a less broad antibiotic, so you escalate or de-escalate, or you discontinue treatment because the influenza test is positive, for example. And you also then determine the duration of treatment for the infection. Now, unfortunately, there's very little data on the use of the antibiotic timeout protocol in the nursing home setting. What is available suggests that it's going to be difficult to carry this out. And I want to make a statement here that I think this is where the nursing home staff, the nursing staff, are important, because they can be the group that really initiates the timeout protocol. In other words, they start the process, they contact the prescriber, and that begins the protocol of assessing response and so forth. Now, the next slide, Clara, can you advance that slide? For some reason, I can't do it. There we go. Of those prescribing processes that I mentioned, the only one that's really been evaluated is duration of therapy. And this has been extensively studied mostly in the hospital setting. But we know now that short course treatment of pneumonia, urinary tract infection, and skin and soft tissue infection is safe and effective. By short course, I mean 7 days and sometimes less than that. And if you want to read about this, there's a excellent review, brief review by Waldecker and Spellberg. Spellberg has been a particular advocate of this approach. This was published in 2019. There's, as I said, very limited information, but what information we have focuses on duration of therapy. Studies in nursing homes have identified excessively long durations of treatment that should be a target for stewardship programs in nursing homes. And this has been extensively evaluated as well in the hospital setting. Sorry, I'm messing up the slide sequence here. All right, I'm sorry, I've gotten out of sync here with my slides. All right, this is now back on the duration of therapy in the nursing home setting. There have been 3 studies that have documented excessively long duration of treatment. One of the important ones is the study by Daneman from the University of Toronto, where they did a population-based study of all nursing home antibiotic use in the province of Ontario. And they found excessive durations of therapy in that study. Kabani as well, and the latest study in 2022 found a similar long duration. All right, well, I'm having a little difficulty here, and I apologize for that. The other thing to look at is other factors that influence the decision to initiate antibiotic therapy. So one can consider provider, resident, family, and facility level factors that may influence the decision to initiate antibiotic therapy. But there's been minimal evaluation of these issues. The one study that I was able to find was a study of over 1,600 US nursing homes that found that several facility level factors correlated with higher rates of antibiotic use. And the list here is as follows: proportion of short stay residents making up more than 75% of facility population, for-profit ownership, the proportion of residents with low cognitive performance making up more than 50% of a facility population, proportion of long stay residents with pressure ulcers making up 5% or more of the facility population, and at least one resident on a ventilator. And this comes from Sarah Kabani and colleagues in 2021. But this is very limited information about these other potential factors influencing the prescribing of antibiotic therapy. So what are the implications for practice and policy and research? I want to make a statement here that's important to understand. Efforts to assess appropriateness of antibiotic therapy in nursing home residents are all well-intentioned, and we've seen many of them, as I've shown you today. However, the various approaches for assessing appropriateness in nursing home residents demonstrates the lack of consensus in how this should be done. The lack of consensus results in data that are not comparable, and I think I've shown you that in some of the information I've given you. So I've come up with a series of suggestions to try to improve the consistency and validity of the assessment of the appropriateness of initiating antibiotic therapy in nursing home residents. So first, we need to standardize and validate clinical definitions of infection for the nursing home setting. And it's possible that a revision of the Loeb criteria may offer that possibility of standardization. But regardless of how the standardization comes about, the clinical definitions need to be validated very carefully. Second, once the standardization and validation has been done, we need to standardize the methodology for assessing appropriateness. We need to standardize how the study population is selected. I've shown you that that's varied in various studies. The evaluation needs to be done prospectively, because retrospectively there is a problem in documentation. And most importantly, the criteria for the clinical diagnosis of infection that's utilized to evaluate appropriateness of initiating treatment needs to be disseminated to nursing home practitioners and staff. You can't evaluate appropriateness of antibiotic therapy unless the people prescribing the medications understand what the criteria is being utilized to evaluate them. Practitioners and staff need to not only be educated regarding the decision to initiate treatment, but also other components of the prescribing process, the antibiotic timeout protocol, for example, and determining the duration of treatment. This is critical. Other issues that need to be addressed when evaluating appropriateness in nursing homes, a distinction needs to be made between residents admitted for post-acute care and those on long-term care, because the rate of antibiotic use in the post-acute population is higher, as the study by Kambani and et al. Showed. They showed that there's higher antibiotic use when there's a large number of post-acute care residents in a facility. Further study of the association of provider, resident, family, and facility level factors also is important, and we need more studies to determine how much influence these factors are playing in the prescribing of antibiotic therapy, to control for them if they're important when we evaluate appropriateness. So let's go back to the clinical vignette that I mentioned before at the beginning, and ask in the near term, after reviewing the literature, what can the ASP team do to potentially improve prescribing in the process of evaluating appropriateness of antibiotic therapy? Well, it's pretty obvious that we need to stop using surveillance definitions to assess appropriateness. My recommendation would be to continue to use the lobe criteria for evaluating appropriateness, even though it has limitations, because it was specifically designed to do this and help providers to decide when to start therapy. However, as I stated clearly previously, nursing home staff and practitioners need to be educated about the lobe criteria and how to use the criteria for prescribing antibiotics. Once all that is done, then you reevaluate appropriateness of therapy. In addition to that, the team should consider developing a timeout protocol and develop a plan to monitor duration of treatment and limit duration to 7 days or less when appropriate. My final comments on this topic are as follows. There is a lack of a gold standard for the diagnosis of bacterial infection in nursing home residents that makes it impossible to construct the perfect set of criteria for initiating antibiotic therapy. And this is not only true in the nursing home, it's true in the hospital as well, and in the outpatient setting. The criteria, because of that lack of a gold standard, the criteria for the diagnosis of bacterial infection will continue to be based on consensus of expert opinion. We can't get around that. However, the evidence base regarding signs and symptoms, localizing or non-localizing of infection, indicating the need for antibiotic treatment, needs to be improved. The experts say that the only way to improve this evidence base is randomized trials. And there are not a lot of randomized trials regarding infection in nursing home residents. And one of the major problem is funding for such studies. And I'm not sure these are going to be done in any reasonable time frame if they're done at all. So we're going to be left with expert opinion on this topic as far as I'm concerned. Well, that's the end of my discussion. I want to thank you for your attention. I want to make one point. If any of you are interested in any of the studies that I listed or talked about in this presentation, or that are in the paper describing this in more detail, and you don't have access to a study that you're interested in, you can email me. My email address is there on the slide, and I'll be glad to email you a PDF file of any of the studies that you're interested in. So thank you for listening.
Great, thank you so much, Dr. Mylott. We're now going to begin answering the questions that were submitted during your presentation. And just as a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Mylott, our first question is, what, according to you, is the role of authorities and community in the creation of appropriate and suitable conditions for initiating antibiotic therapy in the residents of nursing homes?
Give me that again. Give me the first part of that again. I'm sorry.
What, according to you, is the role of authorities and community in the creation of appropriate and suitable conditions for initiating antibiotic therapy in residents of nursing homes?
You know, I don't quite understand that question. Let me be perfectly honest with you. Could you clarify that for me, or?
Okay, if we could have the person that submitted that question perhaps type in a clarification, and in the meantime, we'll move on to the next question, which is, if you work in a nursing home with an antimicrobial stewardship program, is the program monitoring the rate of antibiotic use?
That should be an important role for the team to monitor use. And there's a lot of information about how to do that in terms of metrics. And that's where the pharmacist involved with the facility, or pharmacists, should get involved. Yes, and that definitely should be done. But as I said in the presentation, the distinction should be made between those who are on post-acute care versus long-term care. That distinction has not been well made up to the present time.
Perfect, thank you. The next question is, for appropriate antibiotic stewardship as it relates to UTI management, after initiating ABX and treatment completed, should you reculture with non-localizing S/S?
The recommendation on that is not to reculture, I would never do that. I recommend that situation is in reculturing. No, I wouldn't do that.
Okay, and we actually have a comment from one of our other presenters, and it is that she just wanted to comment that often a behavioral change such as aggression in dementia patients is interpreted as a possible UTI. That's just a comment for you.
Oh, yes, absolutely. I mentioned that this change in status, acute change in status, that kind of behavior is definitely a reason for doing a urine culture in residents. It's very frequent, and the experts in this area, numerous experts in this area, have argued against doing that because of the high rate of asymptomatic bacteriuria in nursing home residents. females particularly have high rates of asymptomatic bacteriuria, as well as males. So the likelihood that you'll find evidence of bacteria in the urine in that setting is fairly high. And as I said previously, people have looked at delirium and the association with urinary tract infection, and the results are contradictory. But this is a common sequence, this dogma, that this kind of behavior is an indication of urinary tract infection. And there's a lot of work being done to try to deal with this particular problem at the present time.
Okay, thank you so much. Our next question is, I believe you mentioned this briefly and this person missed it, but can you tell us if this applies also to patients who live at home or in independent or assisted living facilities?
Well, theoretically, it would apply in the assisted living situation for certain, because assisted living facilities have evolved into having some people who live there who ordinarily, otherwise, in the absence of assisted living facilities, would be in nursing homes. So it probably applies, but there's very little information about the use of antibiotics in assisted living facilities. But my presumption is that a lot of times the same issues are going on there. In the outpatient setting or people living at home, I really can't answer that because there's no information about that. But one might guess or speculate that there are issues like this going on in the outpatient setting as well.
Perfect, thank you so much. Our next question is, can you comment on the role of the infection control preventialists and their training or lack thereof?
Well, I think the problem with infection control in the nursing home setting is that the infection control, the person doing infection control, usually a nurse, a registered nurse, or occasionally an LPN, they have multiple other responsibilities. And besides doing infection control, that's a problem in many nursing home settings. And they obviously have a role in the stewardship activities, but the importance for them is really to be looking at the infection rates in the facility, and often the infection rates that the infection control nurse detects don't agree with the amount of antibiotic use that's going on, and so that there's this disconnect between those two things, mainly because the definitions that they're using now, the revised McGear criteria, are fairly strict, and so they don't, as I tried to emphasize, they don't apply in terms of antibiotic initiation. And so the infection control person needs to be aware of that, and often that may not be the case. So but they need to be part of the process in terms of stewardship, but they need to understand that the surveillance of infection is different from the stewardship activities.
Perfect, thank you so much for your response. Our next question is there any benefit to using a prophylactic meds, for example, ascorbic acid, for UTI prevention in LTC for patients with recurrent UTIs?
The debatable issue, and in my experience, I've argued against that. And there's studies that were done probably 30 years ago now that attempted to do this in randomized trials, And what they found was that the using prophylactic antibiotics versus not using prophylactic antibiotics did not really prevent infections, and it promoted resistance. So I don't think at this point anybody would recommend using prophylactic antibiotic therapy to prevent urinary tract infection in a nursing home resident at this point in time. I just don't see that as an appropriate thing to do. But the studies were done, quite a number of years ago to try to deal with recurrent urinary tract infections in nursing home residents. This is also a major issue with people with Foley catheters, and all that does is promote resistance, and it doesn't reduce episodes of fever that might be related to urinary tract infection or death, for that matter.
Perfect, thank you. Our next question is, what do you think of D-mannose as a preventative?
I don't have any information on that. This has to do with, I believe, adherence of bacteria in the bladder or reducing adherence. But I don't have any other information to advise anybody about that at this point.
Okay, I think we have time for one final question, and the question is anyone evaluating appropriateness of initiating antibiotic therapy in a nursing home as part of an antimicrobial stewardship program? And if yes, what criteria are you using to evaluate appropriateness? Would you like me to repeat the question?
Are you asking me that?
Yes.
Oh, I'm sorry. Yeah, one more time.
Is anyone evaluating appropriateness of initiating antibiotic therapy in a nursing home as part of an antimicrobial stewardship program? And if the answer is yes, what criteria are you using to evaluate appropriateness?
Yeah, that particular question should be addressed to someone who's listening in. Actually, I think that was the meaning of that. That question. If anyone out there listening, participating in the conference, is working in a nursing home with a stewardship program, and are they actually evaluating appropriateness, and what criteria are they using? That was meant to be someone in the audience. I really can't answer that question because I'm not in that setting anymore. Am I making myself clear?
Yes, you are, but we are actually now out of time. So
Okay.
Dr. Nishira, let's invite you back on here.
Okay, thank you so much, Dr. Mahalat. That was really a very informative presentation. And to answer the last question, I think antibiotic stewardship programs vary in different facilities. They may not follow the same guidelines. The knowledge level and implementation level can vary. So, and I recently given in service at our local facility where the infection preventionist, who is the assistant director of nursing, really was not even aware that reculturing was not necessary and was still vague about the concept of asymptomatic urinary tract infections. So there's a lot of work to still be done. So I'll now proceed to our next presentation, and I want to introduce Dr. Patricia Gaffney, who has been a longtime colleague at Nova Southeastern University. She's a professor in the Department of Audiology, earned her bachelor's degree from the George Washington University, in Washington, D.C., Doctor of Audiology from the University of Pittsburgh. She's previously worked with the VA Medical Center in Miami and joined the audiology department here at NSU in 2007. We often reach out to her to educate us about vestibular diagnosis and treatment. She teaches vestibular and amplification courses here and is a clinical preceptor for audiology students. She's a subject matter expert in our grant and has presented at various national and state meetings on various topics, including vestibular amplification and professional issues. She served on the board of directors of the American Academy of Audiology, the American Academy of Audiology Foundation, the American Balance Society, and the president of the Audiology Practice Standards Organization. Currently, she's president-elect for the American Academy of Audiology. And on a personal note, this is a topic I still find medically complex and difficult to decipher in my patients. So I'm looking forward to your presentation on dizziness in the aging population. Welcome, Dr. Gaffney.
Thank you so much for having me. And, we have had such a long history together, so I'm very excited about presenting for this conference. I really have an affinity towards the aging population, and they are really complex when it comes to dizziness. So like Dr. Pandya mentioned, I am an audiologist, so I will be approaching this from the audiology point of view. Okay. So I think audiology often gets overlooked because we're a pretty small profession. There's about roughly 15,000 audiologists across the country. So it's pretty small compared to a lot of other healthcare professions out there. And so, as audiologists, we're looking at evaluating, diagnosing, and treating mostly hearing disorders, right? So hearing loss, tinnitus, hyperacusis, so loudness tolerance issues, auditory processing issues. A new area of expertise coming up is misophonia, people who get really annoyed by sounds like mouth sounds and chewing. But one subspecialty is vestibular and equilibrium disorders. So we are even a smaller set of audiologists who deal with dizziness. And dizziness is really complex. When we look at overall, the complaints of dizziness, it's really common complaint, especially in outpatient clinics. Patients often say that they have some sort of dizziness when going to see their physicians or PAs or other, nurses or other healthcare providers. But dizziness as a term is really vague and is not, a true diagnosing word, because for everybody, dizziness means something different. And so we have to kind of drill down into what dizziness really means. And there's some, various references out there that kind of categorize dizziness into four main categories of vertigo, meaning spinning or rotation. You have lightheaded, disequilibrium, and then that pre-syncope feeling like you're going to pass out kind of feeling. And so, when I'm doing a case history with a patient and they talk about being dizzy, to me, that's not enough of an answer. I need to know what type of dizziness. How do they describe it? Because as people describe their dizziness, those different terms that they may use actually have different connotations as far as what the potential etiology can be for that patient. And it is hard to describe, certain pathologies or certain etiologies of dizziness can be more vague. A lot of my anxiety dizzy patients really have a hard time describing that sensation that they're feeling because it is somewhat, vague and not easy to describe. Other patients, it's very clear, like I roll over in bed and the whole world is spinning. And so, taking that time to really drill down into that further description besides dizzy can be really helpful in determining, what is that next course of action. And so there's an example of some different types of complaints. And as I look through that list, there are certain ones where I look at that and I'm like, oh, this is probably going to end up being cardiovascular. This one is probably going to be, more anxiety. This one is going to be, labyrinthine inside the inner ear. As I'm listening to them describing it, or as I look at that example of a list. The other thing about dizziness is that it has a huge impact on quality of life. And um, I think that because it's so commonly, you know, given as a symptom, I think sometimes it gets brushed aside, especially because dizzy patients take up a lot of time, and in a busy clinic you may not have that time to really have a long discussion. But it can impact what they can do on a day-to-day basis. How can they even drive? Can they function at work? Can they function with their activities? If it's somebody who's retired, but they like going to play golf, or they like going to do different activities, how much does that really impact their day-to-day experience? And so this is what we're trying to get at. And there's a lot of different causes of dizziness. So, in my realm of audiology, I'm mostly looking at, inner ear dysfunction. However, there are some common um, disorders that come up that we see often, like migraine, anxiety, that are not necessarily inner ear related, but we see them often enough that we know, kind of that next referral source. But there's a lot of things that can cause dizziness. And I think this is one of the other major issues from a healthcare provider point of view, is that there's all these things. So how in 15 minutes do you figure out what to do? And that's a really that's really tough. Um, there are some newer um, there is some newer data out there. There was a study done at Mayo Clinic in Rochester, where they utilized artificial intelligence. And so the Rochester Mayo Clinic has a lot of patients. They have a very long waiting list to see dizzy patients, and they created an artificial intelligence algorithm to look at, what are the symptoms, who are the providers involved, between audiology, physical therapy, ENT, neurology, psychiatry, and then what are the outcomes. And one of the things that they found is that kind of putting audiology first in that line actually helped to streamline things, because the audiologists who specialize in dizziness and balance have a pretty good way of recommending that next source, because we often have more time. My vestibular appointments are 2 hours long, and so I have more freedom of time to kind of dig deeper. And it helped cut down on unnecessary appointments. So patients who were referred to ear, nose, and throat first, but were migrainers, ENT really didn't know what to do with them, and so they would send them to audiology. Then audiology would recommend neurology. So when we think about what's going on with dizziness, it really is very broad, and so this creates other caveats to care. So here's some kind of general overview of different types of etiologies for dizziness and vertigo in the older adult population. So we have kind of this inner ear vestibular peripheral problem, which are, number one is typically benign paroxysmal positional vertigo, or BPPV. But we can have some other things like vestibular neuritis, which is an inflammation of the vestibular nerve, has no impact on hearing. Bilateral vestibular loss just because of aging, late onset Meniere's, or a decompensation of a previous insult to the labyrinth. Labyrinthitis, which is an infection, either viral or bacterial, in the inner ear, which does affect hearing. Or we could see occlusion of the anterior vestibular artery. We then can move into, central nervous system issues like vestibular migraine, TIAs, neurodegenerative disorders. We have cardiovascular issues. One that we see quite often is postural hypotension. medication-induced dizziness. Then we have kind of this multifactorial component. And then there's some other things that can pop up, like anxiety or other psychiatric disorders, or just loss of proprioception and somatosensory function. So I just wanted to step back, just kind of going back to the ear. I always, go back to anatomy, physiology, and what's really going on. And when we think about the inner ear, we're talking about, part of the body that's like the size of a dime, right? It's super small. And so when we look at this, we have, obviously everybody's, used to seeing the pinna, or the outer portion of the ear canal, eardrum. We have this middle ear space with the ossicles, and then we have this inner ear, which is divided basically in half between the cochlear side and the labyrinth side. And the labyrinth side is actually pretty basic. It's been around way longer than the auditory system. There's some data that shows that the vestibular system is like 600 million years old, going back to like primitive forms of like jellyfish and things like that. Obviously, it has evolved over time. But what we're looking at in humans is we have two otolith organs. So we have our saccule and our utricle. Both of those are gravity sensors, acceleration, tilt, centrifugation. The utricle is, our primary source of BPPV issues, the benign paroxysmal positional vertigo issues. And then attached to that, we have our three semicircular canals. So our posterior canal down here, our lateral or horizontal canal, and then our anterior or superior canal. And so our semicircular canals detect rotation or angular movement. And so both of these structures are fluid filled. They are set up differently. So with the semicircular canals, we have this cupular structure here, which basically is almost like a swinging door. So depending on which way the fluid is moving, based on how you're moving your head, that cupula is going to deflect in one way or another, which then drives your vestibular ocular reflex. So basically making sure that when you turn your head, that your eyes are keeping up. We then have our otolith organs down here. They have a layer of otoconia. And so that layer of otoconia helps detect things like gravity, big one, but acceleration, tilt, centrifugation. These otoconia are made of, well, they are a calcium carbonate crystal. And so that comes up when we talk about BPPV because of that calcium component. And so we have these structures that are meant to be somewhat redundant to let us know where we are in space. Now, I just wanted to point out a little quickly here about what types of evaluations are done by audiologists to determine, if this is inner ear or what other things could be going on. And so some of our evaluation tools are listed here. So obviously a hearing test is really important. Especially with our older adult population, presbyacusis or age-related hearing loss is very common, but we want to make sure that there's no other issues, like there's no asymmetry to the hearing, that, that we're not missing something. There's not, some sort of inner ear or middle ear infection that's causing, any sort of dizzy complaints. Tympanometry and acoustic reflexes let us know how the tympanic membrane or the eardrum is functioning, as well as that middle ear space, so the ossicles, and then our acoustic reflex. So then we move into our vestibular testing. So I think a lot of people who refer for dizziness are familiar with VNG, or the old version, which was ENG. So VNG is that patients wear video infrared goggles and we record eye movements. They kind of fall into three major categories of ocular motor function, positional, and then calorics, which is allowing us to test that horizontal canal each side. Rotary chair is not as common in most clinical practices, but that also allows us to look at that horizontal canal and some of the central processing of movement. Newer technology is the video head impulse test, or the VHIT. This allows us to look at all 6 semicircular canals, which is really the first test that allows us to look at individual function of the vertical canals, the anterior and posterior. And then we have 2 different VEMPs. So the ocular vestibular evoked myogenic potentials test allows us to evaluate the saccule, and the CVEMP, the cervical vestibular evoked myogenic potential, allows us to evaluate the saccule. So our 2 otolith organs. And then computerized dynamic posturography is to look at overall balance. So when we look at vestibular findings among older adults, when we're looking at it by age, so this vertical axis here is by age, we see that, so a few things to kind of note. So bilateral weakness, meaning that both labyrinths have reduced function, we see that starts pretty young, but it has a really wide standard deviation. And so this can really happen at any point in time. We also see that BPPV has a slightly later onset, so that benign paroxysmal positional vertigo, which I will talk about. And then the later onset we really see is central abnormalities, whether it's brainstem. More often than not, it's typically cerebellar, but it can be brainstem as well. So when we look at the cause of the dizziness, and this was looking at older adults in a primary care facility, we see that cardiovascular is going to be pretty high as far as a total etiology. And that, most of that is really outside the scope of audiology, although we do see patients who are referred who do have orthostatic hypotension. And then we also see, peripheral vestibular disease, and then drugs. So, looking at polypharmacy or other sorts of medications that cause dizziness would be important to evaluate as well. I wanted to throw out this questionnaire. It's a little bit long, so it can be a little tedious, but it really was designed to be used by physicians, PAs, nurses to help triage patients to determine where the course of action really may be for these patients. And it has subscales that help kind of narrow down the potential diagnosis of the dizzy patient. Most of these are labyrinthine in nature, like BPPV, superior canal dehiscence, neuritis. Vestibular migraine is a migraine. It's just a version of a migraine, so neurology would be your best recommendation there. Unspecific dizziness or unsteadiness, they should have a workup and probably a referral to physical therapy. And then persistent postural perceptual dizziness, or 3PD, has a big psychiatric component to it. So the questionnaire looks like this. Like I said, it's a little tedious. I actually have patients fill this out, and then when I use it, I don't use it on every patient. But when I do, I actually have a Excel spreadsheet where I just put in their scores and it calculates all of the subscales for me. So if this is something that you think you might want to incorporate, just email me. I can send you the article, and I can send you my Excel spreadsheet too, so that you don't have to reinvent the wheel with that. So when we're talking about dizziness in these older adults, or any patient really with dizziness, the history is the key component. We really say that in the vestibular world that the history is about 80% of your diagnosis. The testing kind of helps confirm or narrow down if you have more than one thing that you're thinking. So, the initial versus current symptoms. So, what was the onset? How has that changed? Is it one event? Is it multiple events? Are they getting better? Are they getting worse? Are they staying the same? Is it provoked by something? Is it provoked by motion, head position? Is there hearing loss involved or no hearing loss involved? Is there aura like we would see in a migraine? So visual aura, like, you know, the sparkles, the scotoma? Are they having photophobia? Are there any facial symptoms? Like we would see, sometimes you can see that in migraine where they have like circumoral paresthesia, or are we talking about facial symptoms like with acoustic neuroma, vestibular schwannoma, where they're getting facial weakness? And then is there any other family history? Like migraines tend to run in families. You can see sometimes Meniere's can run in families. So that's also important. So I divided some pathologies into whether they're acute, if they're gradual, or if they're just kind of a constant dizziness. So we're going to start with acute. So acute meaning that we have this sudden onset, and then when we're looking at acute, we want to see, you know, how long is that episode? Typically with our benign paroxysmal positional vertigo patients, true BPPV is less than a minute. They may feel kind of off for a couple minutes, but really that true spinning sensation in most cases is about 15-30 seconds max. But when we start looking at greater than about 20 minutes, we start getting into some of the other concerns like Meniere's disease. Although not typical to have an onset later in life, it can. Vestibular neuritis, labyrinthitis, stroke is one that people are usually concerned with, or concussion or mild TBI. So when patients have this sudden onset of dizziness, especially true vertigo, they often present to the emergency department because they're afraid they're having a stroke. And so then the key is to determine, is this really labyrinthine or is this a stroke? And obviously you don't want to misdiagnose them one way or the other. So there are some flow charts out there. This is an example of one. And the one key screening that's being used is called the HINTS. So the HINTS stands for head impulse, nystagmus, and test of skew. And it's being used by clinics and emergency departments to try to differentiate labyrinthine from stroke. And so if done well, it can have really good sensitivity and specificity at determining the difference. And so the first part is the head impulse test. That's the HI part. So the head impulse test is a way to evaluate if there is a loss of labyrinthine function of one or both ears. And what we see is a corrective saccade or a catch-up saccade while they're doing this. So what we're seeing is that with loss of one labyrinth, we're not getting the drive to the vestibular ocular reflex, and so the eyes are not staying stable with this head movement. And the head impulse test, if you do it well, has some pretty good sensitivity specificity. If it's even done by a non-expert, it's still pretty good. So the technique for this is you hold the patient's head, they're facing you. I'm going to show you a video on the next slide. But they're staring at your nose as a fixation point, and then you're going to tilt their head down and impulse their head back and forth, which is basically a quick jerk. You don't need to move the head very far. The key really is the speed. It has to be a really good, quick kind of movement to the head. And then you're watching their eyes. So here is some schematics. I'm going to show you this video. And so he's just kind of loosening up the neck so you can see that quick impulse. So her eyes, so you can see it right there. Let me go back. So eyes stay centered, this one. And then you can see the eyes kind of click over. So to the right, she's normal. To the left, she's abnormal. And you can see the eyes kind of click over. So that's that catch-up saccade when he's impulsing to the left, which means that she has a normal right labyrinth, but the left labyrinth is abnormal. And this is looking at horizontal canal of the semicircular canals. Obviously, then the next letter is N for nystagmus. We're looking to see if the patient has nystagmus. And we can actually differentiate whether it's a peripheral cause nystagmus, because if it is, it will follow what's called Alexander's law, where it will increase if they look in the direction of the fast phase of the nystagmus. If it's central, it can be vertical nystagmus. Anytime you see vertical nystagmus, that's true vertical, no torsion to it. True vertical nystagmus is always going to be a central cause. But if they have direction changing, where it's beating one direction and then switches the other directions, or if they have failure of fixation, where you tell them to stare at something and they're still getting nystagmus where it doesn't reduce, those would be central causes. And then test of skew would be looking at doing an alternate cover test to see is there a deviation in the eye set. And so in a utricular abnormality, if it's an abnormality in the utricle, you can see a very, very small, it's actually hard to see just looking at a patient. There is some very small skew that way, but if it's brainstem involved, then that skew will be significantly larger. And so you can kind of look to see, okay, is this following more of a peripheral pattern? Especially if it's following Alexander's law, then it's probably labyrinthine. If it's following more that central pattern, then you absolutely want to follow up with imaging, particularly MRI, but also ask about hearing loss as well. So another acute abnormality would be TBI or concussion. So fall-related TBI is there's a very high incidence in our older population. With these patients, there may be some slight vertigo, but more often than not, they complain of lightheadedness, particularly that's exacerbated by head movements. And so, you know, TBI in older adults accounts for about 80,000 emergency room department visits every year. And so, and it also leads to death and significant impact on quality of life going forward. So, you know, if it's fall related, you know, obviously, you know, neurology and more likely physical therapy. Our vestibular testing is not really great at picking up mild TBI and concussion. The place where it does pick up is sometimes on our ocular motor testing, and then if they have secondary BPPV. If we move into more intermittent dizziness, this is where we have benign paroxysmal positional vertigo. So these are going to be episodes of dizziness that's going to be head position or body position provoked. So with BPPV, the symptoms are true vertigo. The world is spinning because what's happening is we have these otoconia that are in the utricle that fall out and they fall into that posterior canal. And so when they move their head, these little tiny crystals are just basically rolling around inside that semicircular canal, causing dizziness. And so it lasts less than a minute. It is true vertigo. It fatigues, meaning that if they lay down for a period of time, that it's probably not going to provoke again right away. If you're testing them in an office, if you do more than one hall pike, you're going to see the response get less and less. But with our older adult population, they are 3 times more likely to get BPPV. It's very common. It has a high rate of occurrence, meaning that if we treat them, it has a potential to come back at a later date. And it's hard to predict who that's going to happen to. When I treat BPPV patients, I often say, like, I can't tell you whether it's going to come back or not, but just know if it does, this is what it is. The other thing is that they have a lower effectiveness of repositioning maneuvers. So, you know, you either are going to have to reposition them more than once or it's going to come back. So we have these otoconia coming out of the utricle. Most of the time it's posterior canal just because of gravity. So with our older adult population, that, you know, those who have BPPV actually you can see that they have an impaired gait, they have reduced walking stability. Older adults who were admitted to the hospital for a fall, 54% of them actually were positive for BPPV as well, and that the number of falls were reduced post BPPV treatment. So if you have a patient that's, you know, complaining of falls, it would be good to evaluate them to see if they have BPPV. So this is what an otoconia looks like. So this is a normal one. They're kind of a long hexagonal shape, but over time they can degrade. Particularly, we see this with patients who have osteoporosis because of the calcium component of the crystals. There are diagnostic criterion available to diagnose them, but most often you're going to see posterior canal because of gravity. So if you use the Hall-Pike maneuver, you're going to see this upward torsional nystagmus. Horizontal is also possible. Anterior is pretty rare, especially in our older adult population, because you need to get that otoconia up and over the top, which just isn't something that happens. We usually see that in either more traumatic causes of BPPV or younger people who are doing, weird things. Like I had one patient, she was doing headstands in yoga and ended up with anterior canal. I know a lot of people are familiar with the Hall-Pike. You don't have to do head hanging. Your patient getting dizzy in bed isn't hanging their head off the edge of a table. So I typically do a more supported approach. So you can see here, his head is on the table. We're just getting a little bit of angle with this pillow. You can even do it completely flat on the bed on your table and doing more of a head chin tilt, like you would like a CPR, right? You tilt that chin up. The biggest thing is that you want the head off to the side that you're testing, so either kind of 45 degrees to the right or 45 degrees to the left, and then just look at the pinna. If the top of the pinna is towards the floor, you're good to go. So you don't necessarily need to do a full head hanging. It's not comfortable for the patient. It's not comfortable for the provider. So I just wanted to show you some nystagmus. So this is a patient with posterior canal. So you can see that kind of upward bouncing of the nystagmus. There's also a torsion to it. It's a little hard to see in some patients, a little easier to see in others. I have another one here. And they usually want to shut their eyes because the whole world is spinning. But you can see the torsion of the nystagmus. And then another one. So you can see that nice bouncing. There's options for treatment, so whatever the canal is affected, we can treat it. The other thing I wanted to mention is just calcium and vitamin D. There is some literature out there looking at calcium and vitamin D to support reduction in BPPV. So if you're interested in that, you can take a look at that. So orthostatic hypotension, so this is a very short-lasting dizziness. When people get up, we often have patients who are like, oh, when I stand up, I just take my time because I know if I move too quick, I'm going to get dizzy. So, if you're seeing patients and they're complaining of dizziness, please check them for orthostatic hypotension before referring them for vestibular testing or any other sort of dizziness evaluation. So, supine and sitting, or sitting and standing, to determine if there is that drop in blood pressure. And there are some guidelines out there on orthostatic dizziness as well. And we know that orthostatic hypotension can lead to falls. So if you are taking blood pressure, it is valuable to assess that, because falls have, such a big impact on mortality and morbidity. And then last up, we have gradual or more constant dizziness. So presbyvestibulopathy is age-related dizziness. So we're looking at individuals over the age of 60, and approximately 50% of them have some sort of vestibular loss. So just like we see, age-related vision loss, age-related hearing loss, this is age-related loss to the vestibular system. It also can go by other names like presbyvertigo or disequilibrium of aging. And there are diagnostic criterion for this. This is published by Baronnet Society, which is a multidisciplinary society for dizziness and vertigo, vestibular issues. So these are patients who have at least 3 months of either postural instability or unsteadiness, gait disturbance, chronic dizziness, or recurrent falls. They do need a vestibular workup for us to determine, if there is bilateral vestibular loss. And generally, this is individuals over the age of 60. So individuals with Presby vestibulopathy also have high reported disability via the Dizziness Handicap Inventory. We see that it's higher in women than in men, and it can have a significant impact on walking. Fear of falling can lead to obesity because they're not getting out there and exercising and walking around. So we do want to, evaluate them. The other thing is that these patients are very high risk for falls because not only do they have, damaged labyrinths, but when we look at overall balance, which is mostly controlled by vision, vestibular, and somatosensory, our older adults often also have vision loss and they may have somatosensory loss, which puts them kind of at that high fall risk. Polypharmacy, taking a look at their medications. Dizziness is a very common side effect of medications. And so we want to make sure that, if possible, either, restructuring when they're taking their medications to reduce any dizziness. The patients that I see where I take their list of medications and I kind of look them all up, I do make recommendations that they talk to their pharmacist and their physicians about when, which medications they're taking, should there be any differences in timing, are there things that could be switched? So just kind of keeping an eye on the medications that patients are taking as well. And there are a number of medications out there that can cause dizziness as well as other, side effects, and a lot of them causing orthostatic hypotension. Ototoxic medications, so particularly gentamicin, amikacin, the aminoglycoside group of medications, as well as certain chemotherapy drugs like cisplatin and carboplatin are ototoxic to the inner ears, either cochleotoxic to the hearing side or vestibulotoxic. So just keeping an eye on patients who are, on those aminoglycosides or on those platinum drugs to send them for evaluation for hearing as well as balance. Here's a full list of drugs that are considered ototoxic. Well, this isn't the full list, but this is the most common list of drugs that are ototoxic between the aminoglycosides, the platinum drugs, some loop diuretics, and then just other things like quinine and salicylates. I just wanted to mention vestibular schwannoma. The incidence in older adults is fairly low. It's about 14% compared to everybody who has vestibular schwannomas. But some key things to keep in mind: they're going to have a more gradual onset. It's going to be more lightheaded, a vague dizziness, gradual unsteadiness, and then they're also going to have auditory symptoms. So asymmetric hearing loss, asymmetric tinnitus. So a full, audiologic workup, both hearing and vestibular, as well as imaging. And you can see, we want to catch that neuroma while it's small before it starts to invade the brainstem space. And then last thing really is multifactorial. And this is what really makes a lot of our older adults hard to work with, is in the realm of dizziness, is because, and a lot of times there's more than one thing going on. And, you're trying to piece apart, they may have a labyrinthine disorder, they may have BPPV, plus they may have, Presby vestibulopathy. Maybe they also have orthostatic hypotension. And so you're trying to manage all of these different diagnoses, which makes it more difficult to treat, more difficult to diagnose, and just overall difficult to handle. And so it's a complex group to work with. And so these are my references, and there's my information if you have any questions that you want to email to me.
Okay, well, thank you so much, Dr. Gaffney. So we're now going to begin answering the questions that were submitted during your presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Gaffney, our first question is, What impacts of stresses and mental disorders are there on aging dizziness?
So, yeah, so you can have anxiety related dizziness, and those are more situationally provoked. I had one patient who, because of his hearing loss, he was having difficult times hearing people in, say, Publix. And so every time he would go to Publix, he would get dizzy. And it was really an anxiety based dizziness. So we can see that. You can see more chronic dizziness, where it waxes and wanes, and that's that 3PD diagnosis, the persistent postural perceptual dizziness, where it's a psychiatric component that's causing the dizziness, but it's there all of the time. It's not as common. It's also a lot harder to treat. You typically have to approach it from both a pharmaceutical as well as a cognitive behavioral therapy approach, and sometimes vestibular rehabilitation approach.
Perfect. Thank you so much. Our next question is, are there any resources to finding out what audiologists in your area have a vestibular specialty?
Sure. So, on the American Academy of Audiology website, there is a member directory, where you can put in your area code and you can search within a realm, within like a radius to find, and they have what specialties people have, whether they're, adults, pediatric, if they do vestibular testing. There's also the Vestibular Disorders Association, or VITA. That is a website that has, it has providers listed. It has audiologists, physical therapists, and physicians who all specialize in dizziness. And so you can look on that website as well. If you want that information, just email me and I can send you the links to both of those.
Excellent. Thank you so much. Our next question is, does calcium intake or any disorders of serum calcium affect the occurrence of BPPV?
Yeah, so um, there is some literature out there about, um, you know, lack of calcium or reduced calcium causing BPPV, because the body, as it's trying to take up as much calcium internally, like from the bones and things like that, it can leach it from the otoconia. Um, and so there are some studies out there looking at that, and that's why supplemental calcium and vitamin D to help with the uptake of calcium is recommended. it, there is some conflict in the literature, though, I will say. Overall, it's that that extra calcium can't hurt, because overall the body needs it and it can help. But there are some articles out there that show that it may not be as effective as we would hope. But overall, if they are calcium deficient, that it can't hurt.
Okay, perfect. I think we have time for one more question, and the person says, excellent presentation. And what are your thoughts on over-the-counter hearing aids?
So, so I here's my thoughts on over-the-counter hearing aids. I think access to care for people who need that access is good. I'm currently in a Master's of Public Health program, and it's all about disparities in healthcare. And I think that y- you know is that product going to perform the same as a product fit by an audiologist? Probably not. But if that's what the patient can afford, if that's the access that the patient has, then I think that that's worthwhile. I'd rather have somebody fit with, I'd rather have somebody buy over-the-counter hearing aids and wear them than wear no hearing aids at all. So, I think I think access to auditory information is important for quality of life, auditory deprivation, cortical, plasticity, all of those things. So I'd rather somebody wear something that they can either afford, access, you know, or, just get their hands on, rather than nothing.
Great. So thank you so much, Dr. Gaffney. I still have to go back to the basics and study this again. It's a complex area, but you really always shed some more light on this. We're still peeling the onion.
It's a lot, you know, and it's a lot for us too, you know.
Mhm. All right. And, as you say, when you come into the clinic and you have to try and sort out dizziness, is it something that's benign, something serious, something central? What referrals do we need? But this is great guidance. So we're now at the break period. We have a 15-minute break, and I encourage you all to come back at 10:45 a.m. So we'll see you soon. Thank you. Okay, welcome back, everybody. And I hope you had a refreshing break. We're ready to get started with the second half of our morning presentations. And I'm really pleased to present my friend and colleague, Dr. Paul Katz, who is no stranger to many of you. He's professor of medicine in the Department of Geriatrics at Florida State University College of Medicine, as well as Lake Erie College of Osteopathic Medicine. Currently, he's the corporate medical director for Westminster and Presbyterian Senior Living communities. He has served in a number of leadership positions as VP of Medical Sciences at Baycrest Health Science Center in Toronto, Chief of the Division of Geriatrics and Aging at University of Rochester School of Medicine, and as a medical director for 16 years at Monroe Community Hospital, which was one of the first teaching homes in the United States. Paul is past president of AMDA, the Society for Post-Acute and Long-Term Care Medicine. That's where we first met, I think, Paul. He has co-edited 12 books and over 150 scholarly publications, and he's currently co-editor-in-chief of JAMDA, the Journal of Post-Acute and Long-Term Care Medicine. He has received grants from the NIH, the VA, HRSA, Health Resource Services Administration, and the Ontario Ministry of Health and Long-Term Care. He's part of an international team of investigators working to develop medical provider-specific quality measures and has helped to define the link between medical staff organization models and quality of care. He's an active member of Senior Quality Leap Initiative, which is a consortium of Canadian and US senior care organizations dedicated to quality improvement in nursing home care. Now, let me get my breath back, Paul, after all this introduction. And I want to welcome you and invite you to present your topic of raising the bar for physicians practicing in nursing homes, the path to sustainable improvement. Thank you so much.
Thank you so much, Nashira, and welcome everyone. Clara, see if I have control. Not yet. There we go. Was that me or you, Clara?
That was you.
Okay. Technology. So it's a pleasure to spend a few minutes with our audience to talk about physician practice in nursing homes. And I just want to make it clear that while I'm focusing on physicians this morning, it does not take away from the very important care that is delivered by our other medical provider team, nurse practitioners and physician assistants. I will be alluding to that in a little bit, but I just want to make sure that that's clear from the beginning. I noticed in the first poll that Dr. Milat had inquired about that many in the audience are not in nursing home care, or at least not currently in it. So I will try to give you, try to create a context where I'm making my argument. Because it really, the question is, why should I care about physician practice in nursing home and raising the bar? So in order to explain that, I want to go over a little bit about the changing nursing home landscape, tell you a little bit about what we know of the physician workforce and its link to quality, and the implications for quality of care of what I'm calling raising the bar, which I'll explain in a few minutes, and what our next steps might be. So many of you who are involved in the nursing home understand how the landscape has changed and is changing. And it basically, I think, could be summarized within these three domains, which I'll give you a little bit of information in a minute. One is that our population is increasingly frail. We have nursing home residents now number 1.1 million. Within the United States, there are 14,000 nursing facilities that deliver this care. So whether or not you're involved in nursing home care or not, it's an important part of our healthcare system. So increasingly frail population, we're still beset by significant workforce shortages. And needless to say, there are persistent quality concerns within the nursing home. So let me just give you a few facts and figures about increasing frailty and multimorbidity. These are figures taken from the National Academies of Science, Engineering, and Medicine report just last year, of which I'll give you a little more detail in some subsequent slides. But needless to say, if you look at some chronic conditions that the nursing home population is afflicted with, you see that the majority have some form of cognitive impairment, up to, depending what studies you read, 90% have a significant mental health disorder. Depression affects about 50% of the population. And then we have the spectrum of chronic medical illnesses such as diabetes, heart disease, etc. To put an exclamation point on these comorbidities is the fact that nursing home patients are frail in terms of functional loss. You can see that when you look at basic activities of daily living, so-called ADLs, that almost 9 in 10 will require assistance in at least one of these: bathing, dressing, toileting, ambulation, even transferring from bed and eating. And many of them will have more than one, up to multiple ADL deficits. Well, who is caring for this population? And again, I know I am preaching to the choir, but there is the workforce generically is providing care to this frail population. What I mean by workforce is basically nurses. We'll get into that in a minute. But of course, it takes a village, it takes a team, therapists, social workers, administrators, housekeeping crew, et cetera, et cetera. But I think when we talk about the workforce, I want to focus more in on the nursing. And why? Because we have a fair literature that says nurse staffing is indeed a rate limiting part of the care equation in nursing homes. It is generally accepted, as many of you are aware, that the higher nurse to resident ratio, so-called hours per resident per day, and the higher the nurse competency levels are, those two can directly impact quality. In fact, I think the evidence is so clear that the Biden administration has promised to mandate higher nurse staffing. The question, I think, for the immediate future is whether you can find the staff. You can mandate it, but can you find the staff? And this is just a graphic representing the fact that This area of the pie is RNs and LPNs and therapists. This part of the pie is primarily certified nursing assistants. So the gist here is that much of the workforce is nursing, of course. That's why they call it a nursing home. And in terms of the hours per resident per day, as many of you know, the certified nursing assistants make up the bulk of those hours per resident per day. But of course, LPNs and RNs are still very significant. Okay, so I kind of alluded to shortages. This is a very interesting and depressing few series of slides of a survey conducted by the American Healthcare Association just back in December 2022, random sample of over 500 nursing home providers within their organization. And here are the take-home messages, and I don't think anyone would be surprised at this. 84% of nursing homes are facing moderate to high levels of staffing shortages. You can see in this graphic the question they pose: what is your current staffing situation? And you see both moderate and high level by the majority. 96% of nursing homes are experiencing difficulty hiring staff. 52% saying very difficult. More than half of nursing homes are having to limit new admissions due to staffing shortages. More than half. And finally, more than 2/3 of nursing homes are concerned about having to close their facilities over the challenges of recruiting staff. I won't go into this in any great depth, but the fact that many nursing homes are struggling financially with return on the operating margins very, very low, sometimes in the negative for the majority of nursing homes. We're talking about survival of the industry in many ways. Well, not surprising with the workforce shortages, there have been, and this is even before COVID, there have been persistent quality of care issues. How do we know that? Well, for those of you who don't know a lot about nursing homes, there are a number of federal regulations that mandate periodic surveys of nursing homes at least once a year. And the surveyors look for deviation from standards based on a number of publicly reported quality measures. For example, the prevalence of pain or prevalence of pressure ulcers in the nursing home facility, depressive symptoms that are not being treated with antidepressants, the rate of functional loss, and on and on. There are at least 26 of these publicly reported measures that are used. And then when a deficiency is found, they can impact not only how much the nursing home is getting paid, but they can impact star ratings, which is something that the government tracks from 1 to 5. And that is what consumers use to some degree in choosing facilities. So it has a lot of potentially negative effects. So here's a listing compiled by the Kaiser Family Foundation on deficiencies in certified nursing facilities, just to show you that things are getting worse, not better. This is from the years 2015 to 22. If you look on the right-hand, the left-hand column here, the share of nursing facilities receiving a deficiency on one of those quality measures, but for actual harm or jeopardy, as it's often categorized, you see that the trend is getting worse. Not so much the number, but it's getting worse. These numbers are bad enough. And if you look at the average deficiencies per facility, even pre-COVID, the trend was to increase the number of deficiencies. Now, some will argue that the survey process is flawed and these quality measures are not really as relevant as the government thinks they are, but we cannot ignore the fact that these quality of care issues persist. If you look at the number and prioritization of complaints, this was from the OIG report, Office of Inspector General a few years ago. You see that the total number of complaints, at least up to 2018, were increased, and the percentage of complaints prioritized as high priority are remaining about the same over those ensuing years. And if I had to guess, if we had 2022 data, they would look similar to this. And as one would suspect, there's no shortage of recommendations on how to improve quality, of which we welcome, and this is something that we need. Starting with the Nursing Home Reform Act, which was embedded within what is often entitled the OBRA 86 legislation, Omnibus Budget Reconciliation Act. Starting with that Reform Act, we've had subsequent Institute of Medicine and Inspector General reports, all basically saying the same thing, that there are major quality issues that we need to address. The most recent report is from the National Academies of Science, Engineering, and Medicine report that I alluded to earlier, and it's entitled The National Imperative to Improve Nursing Home Quality. If you have an interest in this, which I'm presuming most of us have, and you haven't seen this report, I would welcome, it's free, you can download it, and at least to have the executive summary. It's a very well done report. But when I reviewed this, because now I'm going to get to the discussion about where the physician workforce fits in, my take-home message when I read this report was that there continues to be an underappreciation for the physician role in nursing homes. That's despite the fact that within the report, it's clear, and they mention this, there are existing legislative and regulatory mandates that define the role of both the medical director and the attending physician in the nursing home. And it's accepted that physicians, and of course other providers, nurse practitioners and PAs, but physicians specifically manage the delivery of all resident care from admission to discharge or transfer to acute hospital. There is even an F tag, this is one of those deficiency tags, labeled A41, that has been developed specific to the medical director and their role. So when you look at the 605-page report, how many of those pages is a physician discussed? 2. And I know it is probably politically not correct for me to say this, but I think this is a major flaw. I call this the Dangerfield effect. Now, for those young people in the audience who don't know what I'm referring to, I'm sorry, but probably most of you do. Rodney Dangerfield was a very well-known comedian in the 70s, 80s, and 90s, whose shtick was, I get no respect, who always wore a red tie, which I probably should have worn this morning. But the issue here is physicians are often an afterthought. Physicians are generally absent from policy discussions impacting on nursing homes, despite significant advocacy from AMDA, the Society for Post-Acute and Long-Term Care Medicine, AGS, et cetera. It has a low priority with CMS, despite what they say. For example, there is still no existing federal repository that lists medical directors and attending. You can go to the CMS site, Nursing Home Compare, and you can see how much staff, what the turnover rate is on the nursing side. There is no such data on physicians. There is also the fact that I believe variable and often suboptimal medical practice in nursing homes. This was particularly evident during COVID. Much of this is anecdotal, but I think any of you who do practice or have practice in nursing homes know this to be true. There's also limited research, although this is evolving, regarding the impact of physicians on quality, and I'll have more to say on that in a few minutes. It's also the fact that physician practice is often not even explored. It's unaccounted for in studies that look at provider outcome. Let me give you an example just to bring this home. We recently published a scoping review article on physician practice characteristics influencing nurse practitioner and physician assistant care in nursing homes. Now, let me be clear. This is not to detract from the evidence that shows nurse practitioner and physician assistants do a very good job, an excellent job in providing care and have very positive outcomes associated with the care. So that wasn't the point of this. But the rationale is that physicians, NPs, and PAs all are key to effective delivery of medical care in nursing homes. And although, as I mentioned, several studies have reported on the relationship between care delivered by a given discipline, specifically nurse practitioners, what we term the mediating effect of physician practice characteristics are pretty much unknown. So we started reviewing almost 1,900 studies. We yielded only 16 that met our eligibility criteria that had to do with nursing home size being 100 beds, having more than one NP or PA involved, and having quantifiable outcomes reported. So what did we find? The study designs, there were no randomized controlled trials. They were generally retrospective and quasi-experimental. That's not the point. The point is the second bullet point here. In no report was the type of physician practice characterized, and no physician practice variables were adjusted for with regard to those outcomes in those reports. The physician practice variables that I'm alluding to included number of physicians involved in that practice. What was their total practice load? What was the case mix of the population? All things that have relevance to the outcomes. Also, the nature of the collaborative practice between the NP/PA and the physician was infrequently specified. So this brings me to the point of the topic, raising the bar. And to answer this question, how to raise the bar, I believe we need to establish practice and accountability standards for physicians to ensure consistent and high quality medical care. I believe that a first step is establishing and promulgating standards of care through either special recognition or specialty designation for nursing home physicians. Now, this is obviously controversial, but I firmly believe, and my colleagues and I recently published an editorial on this in JAMDA. A very important point is whatever special recognition or specialty designation we come up with, it has to be attainable for physicians that are currently practicing in the post-acute and long-term care environment. And I'll give you some statistics about that in a minute. Well, what do we know about physicians practicing in nursing homes? And they're often, the current jargon is to refer to physicians who are devoting the majority of their time in nursing home practice as SNFs, skilled nursing physicians, and non-SNFs. I'm not sure I like that, but whatever you want to call those physicians, and I'll show you some details about comparing those two groups. This was a recent article on actually the characteristics of physicians who practice primarily in nursing homes. This was taken from a 20% national sample of beneficiaries. First bullet point, only a small number of physicians in the country, 12.5%, it may even be smaller than that, billed Medicare for any claims for nursing home visits. So there's only a small number, 1 in 10 physicians that do that to begin with. SNFs were defined for this report as those who had 90% or more evaluation and management visits in the nursing home. Some are using 80%, I'll give you that in a minute. So for this report, 90% or more are defined as SNFs. Now they accounted for only 1.1% of all US physicians, but we're billing for about a third of nursing home Medicare billings. How did the SNFs differ from physicians who don't do any practice in nursing homes? Well, they tended to be older and female. Not surprisingly, they tended to be primarily in primary care practice. They were more foreign trained and more in solo practice. This is really the only good snapshot we have so far comparing SNFs and non-SNFs. Currently, an average of 45% of nursing home residents are seen by a provider who works full-time seeing nursing home residents. So the provider could be a physician, nurse practitioner, or PA. So although this group is small, they're covering almost 50% of all nursing home residents. So it's important. And what do we know about the type of care that's delivered by SNFs? Well, there is an emerging evidence base that suggests that SNFs are associated with decreased rehospitalization rates, more visits on site in the nursing home, having an increase in successful discharge to the community, better management of medications such as antipsychotics, and avoiding potentially harmful medications. The impact of SNFs on Medicare costs and cost savings is a little unclear, so that's still kind of up in the air, but seem to have positive benefits. So you may ask, oh, but before I ask that question, this graphic is from another recent article published in JAMDA by James Goodwin and colleagues in New Mexico. And what I want to have you attend to is the fact that if you look at 2008 and physicians who spent some time in nursing homes, but less than 20%, you'll see that this total number declined in 2017. Now, if we go to the SNFs for this publication, they define SNFs as greater than 80% practicing in a nursing home. You'll see that the numbers actually went up on the physician side and went particularly increased on the nurse practitioner side, so much so that there are more SNFs nurse practitioners than there are physicians. PAs are still a very small percentage. So the numbers of total physicians is declining, but those devoting their practice to nursing homes is increasing. This is just another graphic to show that the percentage of providers devoting more than 80% is increasing. And this is nurse practitioners, PAs, and we'll skip this one. So you may ask, well, Paul, aren't you already answering your own question? Aren't SNFs de facto specialists? Do we need to do anything more? So I think many would make that argument. I would say that because the definition of a SNFs is based only on the percent of practice devoted to nursing home care, it only describes one single component of commitment. Commitment, we know, is directly related to quality of care. It doesn't measure competence. It doesn't measure engagement, or doesn't really take into account the medical staff organizational model, all of which have also been linked to quality. And although those care outcomes that I just described for SNFs are generally positive, they tend to be mixed. So I think the story is yet to be told. Well, are there lessons from other parts of the world that maybe, if we're talking about specialty recognition, where could we look? Well, really, the only place to look internationally is to the Netherlands. And I'll give you a 2-minute history of what happened there. In the 1960s, the Dutch government enacted reforms that provided for funding for all nursing homes, which allowed for the full-time employment of medical providers. That was a key there. In 1972, the Dutch Association of Nursing Home Physicians was founded, probably akin to our AMDA, and they began to develop educational programs for nursing home physicians based on their belief that the current training for primary care docs was insufficient given the complexities of nursing home care. That is exactly the same rationale that guided the development of the AMDA attending physician competencies almost 10 years ago. The efforts by the Dutch Association of Nursing Home Physicians eventually culminated in the establishment of a nursing home specialty in 1989. Initially, they were training residents for 2 years, and that was extended for 3 years in 2006. Importantly, the nursing home residency training programs in the Netherlands was not only formalized, but funded by the government. Interestingly, nursing home physicians have now morphed into what they call elderly care physicians that are not only serving the nursing homes, but they're now serving frail older adults in the community. So the real question is the applicability of the Dutch model, does it have relevance in the US? And unfortunately, I would say no, because for many reasons. We don't have the funding source from the government. We currently lack advocacy from professional organizations and accrediting bodies and the government. Unfortunately, it would have been nice if there had been a comparison study comparing outcomes pre and post the advent of nursing home specialists in the Netherlands. We don't have that. That would be a powerful statement if positive to show that we should be confirming the need in our country for such specialists. However, it's interesting to note that the hospitalization rates for nursing home residents in their last year of life in the US are more than double that seen in the Netherlands. Well, many of you may ask, we already have a specialty. It's called geriatrics. Aren't geriatricians the answer? And unfortunately, the answer is no. Only 6.5% of SNFs specialize in geriatrics. So yes, they're an important component. I'm one of them, but they're not enough of us. And in fact, if you haven't seen this report, I'd like to go over it. It's an unfortunately depressing, sobering report that was published in JAMA just last month by Jerry Gurwitz in Boston. And he labels this a paradoxical decline of geriatric medicine as a profession. First, he notes there's been a decline in board-certified geriatricians from around 10,000 in 2000 to just over 7,400 in 2022, despite the fact that we have an increasingly aging population. Now, the reasons are many of geriatricians are getting older, they're retiring, but interestingly, there's a failure to recertify in a substantial number of certified geriatricians, which you have to do every 10 years. So that may be, they don't see the value in it. I'm not exactly sure. A very important part of this article was that there are fewer trainees in the pipeline. As Dr. Gurwitz notes, in 2022, only 177 of 411 fellowship positions were filled in geriatrics. That's the lowest percentage across 71 specialties of medicine. And in fact, I think it's the lowest percentage for geriatrics in a couple decades. On top of that, at least on the academic side, there are few fellowship trained geriatricians that pursue NIA funding and traditional academic careers. There are many reasons behind the decline of geriatrics as a profession. Dr. Gurwitz notes the disappearance of previous very substantial support for geriatric programs nationally by foundations such as the Hartford and the Reynolds Foundations. There are inconsistent geriatric training requirements in medical schools and residencies to this day, which means that if you're looking for mentorship or a role model, it's going to be hard to find. There's also, Dr. Gurwitz points out, the geriatricians have relatively poor compensation. I'm going to ask my colleagues at FSU to ignore this, not to use it as an arguing point, but it's true that the median salary of geriatricians is 9% lower than general internists and 14% below hospitalists. Another distressing argument or fact that Dr. Gurwitz points out is there's significant ageism. We know there's ageism in our society, but there's significant ageism among students and residents. So if they have this kind of negative stereotype, they're not going to choose geriatrics as a profession. So how do we move forward? You know, I'm a glass half full, so I don't want to leave you with this depressing downer. I think if we're going to make a case for specialty recognition and raising the bar, it requires evidence that specialists or those who get special recognition deliver superior care. And that is a function of competency. Unfortunately, most of the quality outcome measures we currently use, many of them which are based on minimum data set, the quality measures within the nursing home, yes, they're important and informative, but they only paint part of the picture. Typical quality measures such as how much antipsychotics you use or what your rehospitalization rates are important outcomes, but they're driven more by system level factors versus individual provider practice. They are not provider specific, and they do not give you the full measure of what the provider is doing. And this is, you know, the whole priority of looking at competence has been a priority in the National Academy of Medicine for years. They in fact say, this is a report from several years ago, that physician and nurse training in all settings where older adults receive care, including nursing homes, assisted living, and patients' home, there should be a demonstration of competence. And this should be a criterion for all licensure, certification, and maintenance of certification for healthcare professionals. Of course, definitely including nurses. And in fact, they suggest maybe there should be enhanced reimbursement for clinical services delivered by practitioners who have certification. Other leaders in the field, such as McLean, report that we need to start moving away from performance measures that are easy to obtain, the ones we currently obtain through administrative data like MDS. We shouldn't abandon them, but we need others. The new measures should be fully integrated into how we deliver care and address most pressing performance gaps and really be the guide to direct quality improvement. Well, fortunately, I know I'm involved in a international group of investigators that have recently come up with provider-specific quality measures. They're still being refined, and we need to really test them on a large audience, if you will. And these, we don't have time to go into depth about these, but these measures are based on the old assessing care of vulnerable elder measures. So for example, they are if-then statements. If a nursing home resident has had a fall, then this measure says in 30 days after the fall, there should be documentation of the fall examination or documentation that this represents an ongoing problem that's been evaluated. These are the sorts of measures that you're not going to be able to pull out from administrative data. You're going to have to actually do chart reviews. And that is one of the challenges we have in trying to apply these on a large scale. But with the use of artificial intelligence, I think we're on the road to solving that problem. So what I believe is formally recognizing nursing home providers who have a proven skill set and commitment will be able to drive change much like we've seen in the Netherlands. But we have to demonstrate the value add of whatever we're going to call this specialist. I'm going to call it a post-acute long-term care specialist. It has to be based on quality and eventually cost. If we can prove that using some of those performance measures I just mentioned, we will hopefully then be able to convince nursing home facilities to link up and preferentially associated with these specialists. If this were to happen, I believe that government policy would then shift and may in fact demand specialty coverage if we can give them this compelling evidence. Now you say, oh, that's kind of pie in the sky, that's never going to happen. But you know, recently in California, there was legislation passed that requires that all medical directors in California need to be certified through AMDA. So it can happen. You can get this legislation passed. And now it's up to us to prove that people who are certified and have specific training as medical directors in California give better care. It's the same sort of logic rationale I'm using for attending physicians. Well, can we look to other similar professional organizations? And I often use hospitalists as an example, comparison. Hospitalists, as many of you know, starting with a pilot in 2010, were granted this recognition. They called it focus recognition. And they were granted this by the American Board of Internal Medicine. And they chose this focus recognition path over specialty because there wasn't a hospitalist-based residency or fellowship training in hospital medicine. question, could we apply this similar paradigm to post-acute long-term care medicine? Well, no, for a couple of reasons. Unfortunately, only 12% of hospitalists today currently seek focused recognition. So it calls into question the perceived value among those practicing hospital medicine. And the fact is, given the smaller number of nursing home providers, focused recognition just doesn't appear to be a viable option. Nor does specialty recognition, because we don't have residencies or fellowships. So I think a more pragmatic approach, and this is what I'm stressing, may be for the Society of Post-Acute and Long-Term Care Medicine, AMDA, to establish credentials for physicians practicing in nursing homes. AMDA already has a track record in establishing credentials for nursing home medical directors through the American Board of Post-Acute and Long-Term Care Medicine, ABPLM. And we also have already defined the core skills and activities of nursing home attending physicians that very much mirror the AMDA competencies that were outlined, have been outlined and published by Morton and colleagues in JAMDA. So I do believe, and this is my call to action, we need a concerted effort to adopt a special credential. I think that this credential will serve as a validation of specialized knowledge and practice expertise, but we must have a parallel effort, as I mentioned before, that establishes that such competence or recognition actually translates into meaningful quality differences. I think we're getting to, we have the tools now that we can start to do that. If we are able to do that, we'll be able to establish practice standards that will inform questions I get asked a lot about. What is the optimum physician staffing ratio? Is it 2,000 nursing home residents to one physician and one nurse practitioner? No, although you see that. It's much, much less, but we'll at least have standards to go by. It will also inform potentially what the optimum medical staff organizational models are. This is my last slide. I often use this because whatever you're doing in nursing home medicine, it often feels like you're Sisyphus and rolling that boulder up the hill. I really believe, and hopefully in my lifetime, we'll get that boulder to the top and keep it there, and it won't come running down and having to start over. But I am very optimistic we can enhance the quality of care in nursing homes by raising the bar for physicians. So thank you. I did, well, I left about 5 minutes, I think. And,
you did.
Have questions?
Perfect. Well, thank you so much, Dr. Katz. We're now going to begin answering the questions that were submitted during today's presentation. And just as a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Katz, your first question is, can we as geriatricians focus on developing more dual residency training programs with other subspecialties, like we have done with orthopedics, geri-ENT, geri-oncology? Residents must recognize they will be treating these patients in all specialities.
Yeah, it's a great question. I think there have been attempts to do this, particularly with in oncology, and as you mentioned, orthopedics. So the more we can establish credibility and value with our specialty colleagues, that may enhance visibility. It may enhance recruitment. That would be a way. But obviously, we know that there's a fair amount of information now that those sort of partnerships and that dual training increases quality. So yes, I think that's something we need to look at. And I know the American Geriatric Society over the years has been trying to integrate more geriatrics into the basic training of the surgeons and surgical subspecialties.
Perfect, thank you. Our next question is, Dr. Katz, should there be a special track in nursing training for work in the nursing home setting?
Yes, absolutely. Even for, in nurse practitioners, I think in all our training, there has to be exposure to long-term care, nursing home, assisted living, even home care. And if you don't get the exposure, you don't get exposure not only to good care, what standards should be, you don't get role models, you don't get mentorship. So and I think because we don't do that consistently, post-acute long-term care tends to be negatively stereotyped, and that's a major challenge to overcome.
Thank you so much for your response. I think we have time for one final question, and that question is, what is your opinion of medical directors whose major role is to provide directorship in 5 or even 10 facilities?
Oh boy, that's a loaded question. And there's no simple answer. I think, one of my last points was to create evidence as to what the optimum staffing should be. And that, I think, includes medical direction. If all you do is medical direction, and you could probably handle 5 facilities or more, and as long as you're adhering to established guidelines, promulgated by AMDA, et cetera, I think that's perfectly fine. But if you add on another 1,000 patients that you're caring for, or several hundred, in addition to that administrative responsibility, I just don't think you can give good care as defined by our professional organization. I have to prove that. All I have is anecdotal evidence. But, I think we need to put value over volume, which unfortunately many providers are still stressing. Hope I answered that.
Perfect, thank you. And now we'll invite Dr. Pandya back on.
Thank you so much, Dr. Katz. That last question was from me. I have to own up to that. So that was a really insightful presentation, if not a sobering presentation. And I know what some of the geriatric workforce enhancement programs are doing is trying to enhance education in the nursing home setting for all healthcare professionals. So I'd now like to move on to our keynote address, and it's my pleasure to introduce Dr. Eric Ilyaev. He was previously the founder and CEO of myhousevisit.com, an organization that provides medical home visits to the elderly and homebound. In fact, he founded a company after his residency at New York Presbyterian Brooklyn Methodist Hospital. His team, physicians, nurse practitioners, care coordinators, service more than 5,000 patients in the New York metropolitan area. He also served as the regional medical director for the visiting of hospice for the Visiting Nurse Service of New York, which is the largest not-for-profit home and community-based healthcare organization in the nation. He's passionate about medical education and holds academic appointments as Associate Professor of Medicine in Touro College, St. George's Medical University, and is the Vice Director of Undergraduate Medical Education at Kingsbrook Jewish Medical Center. Seeing the complexity of chronic diseases and the opportunity for optimized coordination of care, he founded iConnect.io. I hope I said that right, a technology platform which currently delivers care coordination to more than 5,000 patients. One of Dr. Ilyaev's most rewarding roles is being father to 6 beautiful children, and I believe I've met one of them at a seminar you held, and spending time with his family. I'm astonished that he has time to produce music, and with his latest music video, Chains, having more than 200,000 views on Facebook. So we're delighted to have you as our keynote speaker, Dr. Ilyaev, and you're going to talk about the future of telehealth.
Thank you so much, Dr. Pandya. And I have to say that we actually, the new generation coming up, we stand on the shoulders of giants such as yourself, Dr. Pandya, such as Dr. Milet, such as Dr. Katz, and we thank you for your self-sacrifice and many years of dedication to healthcare in the geriatric space. Thank you so much.
Thank you.
So today's topic for the keynote is going to be re-envisioning elder care. And we're going to talk about specifically age tech. Now, before we go into the presentation, I want to tell you a story. This is a true story of me coming out of residency in 2012. And as I'm coming out of residency, I'm trying to figure out, well, what do I do next? Do I go into office-based, like hospitalist, like many residents coming out of residency, you're thinking, what's the next step? And so a recruiter reaches out to me, and remember, this is 2012. This is before aging in place. This is before moving everything into the home from the hospital. And he tells me, look, there's opportunity to be a house call doctor. I said, house call doctor? This is what folks did like in the 50s, right? He's like, yeah. But he said, I'm going to make it even more interesting for you. We're going to give you your own personal driver, and you'll go to folks' homes and you'll take care of them. And I said, wow, remember, this is coming out of residency, a young individual. My first day on the job, there's a red Audi, beautiful car, and this is for Medicare and Medicaid patients. This is not concierge medicine. A beautiful red Audi pulls up. The driver, who also functions in the role of a medical assistant, has these nice shades on, and I'm like, wow, this is amazing. And so I see my first patient, Mrs. Smith, and I'm there for about 15 minutes, 30 minutes, 45 minutes. It's a complicated case, 70-year-old, multiple comorbidities. And Mrs. Smith looks at me first and she says, doctor, why are you still here? And I said, well, Mrs. Smith, you have like 20 medications, you have a whole bunch of history I got to look into. Well, the other doctors that always came for the past 2 years have only spent 15 minutes here, and they left. So that was kind of like the first lesson to me. Wow, that's interesting. Second lesson, as I'm seeing her in August, straight out of residency, I'm reading in the EHR, and the EHR, it keeps on saying, patient has weight loss, nausea, needs to get CAT scan of the abdomen, rule out malignancy, April, it says that. May, it says that. June, it says that. July, it says that. And here I'm in August talking to Ms. Smith, and I say, Mrs. Smith, did you get a CT scan of your abdomen? What did it say? You need to get it. She's like, of course I got it. I got it back in May, as soon as in April your company came. I said, you really did? Where'd you get it? This hospital. So I happen to actually I just came out of the residency from that hospital. And so I call the radiologist, sign whatever forms I need to sign right on the spot, get it done right away, and say, hey, can we get that report? And I have to tell you, as I looked at that report, this is my first visit out of residency as an attending physician, I had chills in my body because it read, and I remember it as clearly as it was yesterday, and this was more than a decade ago, significant mass in the liver concerning for high-grade malignancy. And now you have to understand, I'm standing there, and this is the first time I meet Mrs. Smith, and she had a CAT scan done in April or May, and it's August, and I have to deliver this news to Mrs. Smith. And I did, and shortly thereafter, after working another day in the organization, I said, look, you guys are amazing, but our values aren't really aligned. And I went home. I said, I'm not going to do this anymore. This is not the way we practice medicine. And as I'm sitting there, I'm thinking, well, what am I going to do next? And my mom's like, well, you should start your own house call here in Queens. and my grandma happened to fall down, didn't want to go to the hospital, and she called the grandson. So I came in, we got an x-ray done in the home, there was no fracture, grandma was okay, and that's how I started my journey as a house call physician. Fast forward 10 years, grew the practice, had a lot of interest from direct contract entities and ACO REACH, and my practice was acquired to be in a full risk model in New York. And we had a merger and acquisition, and I learned a lot. At the same time, I started implementing technology into our practice, and that's what I'm going to talk to you about today. So before we get into that though, let's look at the numbers, right? The US population, I want you to take a look at 1910. Take a look at 1940. 65 and over, you got 10 million, you got 20 million, you got 1990, about 30 million or so. And now 2019, which the data was collected, 54.1 million adults 65 plus. And what folks are thinking and projecting, and this is from the US Administration on Aging, the AOA, that by 2060, we will have 94.7 million individuals. 94.7 Mrs. Smiths that a young Dr. Eric coming out of residency will be seeing. And what type of system, what type of healthcare system will that new Mrs. Smith, that the new Dr. Eric coming out will see, because there's going to be so many more of them, of that specific population. At the same time, let's look at spending. In 2022 and 2000, let's compare. In the year 2000, Medicare had spent a little bit under $200 billion. That's in the year 2000. Now fast forward, and this is again data from the Congressional Budget Office, Medicare benefit payments totaled $744 billion from 2020 to 2022. Now we've got a rise in the number of elderly coming, the silver tsunami. What's going to happen with the spending, say, in 10 years or so? Looking to the future, net Medicare outlays are projected to increase from $744 billion in 2022 to nearly $1.7 trillion in 2033. My apologies. Wow. That is a lot of spending. So what do we do about it? Well, I remember listening to Oprah once, and she said something very beautiful that I always keep and I apply in my life. If you don't evolve, you will dissolve. Okay, what do you mean by that, Dr. Eric? Can you show us some examples? Well, let's look at the taxi industry. I remember when I came to this country, and my parents did in 1988, 1989, owning a taxi medallion was like, wow, that was a big thing. Now, it's not worth anything. They have evolved, well, they have dissolved, but really what's evolved is Uber. What about the Sony Walkmans that we used to walk around with? That has also now dissolved, and it has evolved into digital music. Same thing with retail. We hear a lot about retail suffering right now because digital purchasing has really taken over as the Amazons of the world. That is really, really major. And when it comes to healthcare, if we don't evolve, if we don't change the way that we practice, the tools that we use, the way that we teach our students, that will result in our dissolving. Financially, we won't be able to survive. So with that said, this is a great great book. The book was actually written by Mark Randolph, who is the co-founder and the first CEO of Netflix. And he describes how he, as a young individual entrepreneur, had this dream that the way things were done by Blockbuster, not sure if some of you remember, where we actually had to go to a store, grab a video cassette, take that video cassette, bring it home, put it into a VHS. We had 2 or 3 days to bring it back. And if we didn't, we got a fine. Sometimes the cassettes wouldn't work because the quality would be horrible. And so Mark Randolph, he got a meeting with the CEO of Blockbuster. Can you imagine? At that time, Blockbuster had 9,000 stores all over the world. And he's sitting there in this boardroom and he's speaking to the CEO of Blockbuster and he says, hey, this is not the way of the future. Things are going to change. And the CEO of Blockbuster looks at him in his nice pin suit and says, young man, that will never work. Wow. That will never work. And so today, history has shown, let's just fast forward over here, that out of the 9,000 stores of Blockbuster, there is only one remaining today. Only one in Oregon. And that's as of November 3rd, 2022. I think that's shocking how such a large company dissolved because it failed to evolve. Now, where we are with medicine today is the Blockbuster model. Think about it. Getting an appointment. Here, I tried to get an appointment in South Florida to get a CT scan of the heart with, instead of a stress test for myself. And they told me it will take about 1.5 to 2 months. And we had to jump through different hula hoops to order. That's the Blockbuster moment. And I'm going to present to you 2 cases which will show you the difference between the Blockbuster moment of medicine and the Netflix moment of medicine. I want you to meet Harry. And I also want you to meet Michael. Let's start with Harry. Okay. So I like Harry. Look at Harry's smile. He's smiling. He's happy. He's got a pretty nice hat on. On a Monday, Harry starts feeling a little off. He has a little bit of a cold. He says to himself, well, that's probably nothing. It's just a little bit of a cold. I'll sleep on it. On Tuesday, the cough gets a little worse. Now he has productive sputum. Still says, look, I don't want to bother anybody. On Wednesday, he gets a little weaker. Doesn't get out of bed as usual. Got up a lot later. Had no appetite. On Thursday, he spiked the fever. Then he calls his doctor on Thursday night at 9 p.m. Says, Doc, I'm not doing well. I had this cold and I have a fever and I have a cough. Can you help me out? The doctor says, look, it's Thursday. It's 9 p.m. The weekend's coming out. I can't come to your home right now. I can't really help you. And you sound pretty sick, Harry. The way I know you, you're usually very active and you sound very sick. This is what I want you to do. I want you to call an ambulance. So Harry's like, okay, let me call an ambulance. So on a cold winter night on a Thursday, an ambulance comes, he's put on a stretcher, and he's brought to the emergency room. In the emergency room, there's sounds, ding dong, people walking back and forth. Harry's in his 70s. He's looking at all this. He has an infection. He's obviously going to get a little confused, may even go into delirium, but that put aside, they do an x-ray. And on the x-ray, they find that he has pneumonia. His blood pressure, because it's been since Monday, Tuesday, Wednesday, and now it's Thursday going into Friday morning, he's now septic, is 70/50. So on top of the antibiotics that he started on, they're also putting him on pressors. And as the physicians know in the group, that the pressors, they take your blood vessels and they constrict them so that your blood pressure can go up. Because Harry's not doing well. 70/50 is not good. Now, because Harry is in a hospital setting, in the ICU, he's confused, he's unable to use the bathroom by himself. What comes next? A Foley catheter. A Foley catheter is placed in, and it's a foreign device. And anything foreign to the body that you put inside your body, a metal or anything like that, can increase your risk of infection. And actually, Foleys are notorious for that. So what happens to Harry? Harry gets a UTI, a urinary tract infection, that is resistant to the antibiotics that he was given for his pneumonia. More antibiotics, and now Harry's laying in bed. And he's laying in bed, and this happens all over throughout the United States. And Dr. Katz, Dr. Milet, Dr. Pandya can attest clinically to how we see this many, many times over. And so now Harry's laying in bed, and he develops something called a decubitus ulcer on his sacrum. All started from a cough on a Monday. Harry tries to get better, antibiotics, physical therapy in the hospital. He gets up in the hospital by himself, falls down, poor gentleman, and now has a cast on his left foot as well. Finally, and you could see the difference, right? Harry's smiling here, and here he's very, very, very upset. He's tired, he's exhausted. He's lucky that he made it. So he goes into a SNF because he needs some rehab. And in the rehab, he also gets wound care and wound care at home. And if you calculate, besides the most important is Harry's experience. I want you to think about the experience and the fact that he's lucky to be alive. A lot of folks don't make it out of that situation. And the older we get, especially in the geriatric field, 70, 80, in the hospital, I mean, it's kind of dangerous. It's a dangerous place for an older person. And so look at the cost as well. This is a DRG. This is from New York State. And they range from 12 to 15, 16,000 just for a pneumonia. That's the cost of care just for a pneumonia. Now, don't forget, there's other things that are added to that. The rehab he had, right? The wound care that he had, all these other things, the clinicians, the consultants, the specialists that came in, all of that is not just 12,000. It adds up to 20, 30,000 for that one experience for Harry. And if you scale that, Harry's just one patient. If you scale that to 1,000 patients, 3,000 patients, you could surely understand why our healthcare costs went from 200 to 700 plus billion. And with all these fancy new models coming out, the cost is going up. And so if we don't evolve, we will dissolve. Now, I want to introduce you to Michael. Michael doesn't subscribe to Blockbuster. Michael lives in a world of Netflix. He actually has a smart home. And you can take a look here. He has a home over here. And his home, and I'm going to stop the video here for a sec. His home has all sorts of interesting sensors. A thermometer, a pulse oximeter, a blood pressure device, a scale, a glucometer, an EKG. Also has infrared monitoring as well, where it monitors Michael's steps and patterns of activity. And so Michael has a similar situation, except on Monday, Michael's home, he's not calling anybody. He has the smart home with all the fancy technology that I discussed. And Michael's blood oxygen saturation, heart rate, skin temperature is being monitored. and it's being monitored in a 24/7 command center that is a combination of clinicians, your physicians, your nurse practitioners, and I agree with Dr. Katz wholeheartedly. The value that our NPs and PAs bring is unbelievable. It's really unbelievable. And Dr. Katz, you said you weren't wearing a red tie, but I made sure to wear one for you today. So we're good. And if you look at Michael's home now has a 24-hour monitoring by clinicians and also monitoring by AI and clinical decision support. And so when Michael's heart rate on Monday went up to 107 and his pulse oximeter, his oxygen level dropped from 99 to 94 or 95, automatically that was caught even before Michael calling his doctor. And the doctor actually, and a care coordinator first, called Michael and spoke to him, said, "Hi, how you feeling?" "Well, yeah, I've been feeling okay. Let me connect you to a telehealth visit with a doctor or with a nurse practitioner or PA." So you see Michael sitting here and actually talking now before getting very, very sick to a clinical provider. Provider says, "Look, I'm listening, and because you look a little off and I don't like what I'm hearing, I would like to do this. Michael, can you do me a favor?" "Sure. Can you take the device that we gave you, the digital stethoscope? Can you place it over here on your heart and on your lungs?" "Sure. And can you take a deep breath?" And as you can see the image here, "Great. Take a deep breath. Okay, good. And can you have your daughter or your wife or someone significant other, can you have them put it on the back and take a deep breath as well?" "Okay, yes, yes." And now the doctor, sitting somewhere else, is able to listen to the lungs. Now it gets actually better than that. Where we're going with digital technology and Netflix of medicine is that not only a doctor can listen, but there's a database of all the lung sounds that has already been accumulating. AI then goes and references that database and is able to say, well, based on the wavelengths and audio wavelengths of the lung sounds, this sounds more like CHF. This sounds congestive heart failure. This sounds more like upper respiratory tract infection. That's a wow moment. Very different than Harry's experience. So once that actually happened and the lungs were listened to, the doctor felt, then based on the clinical decisions, also felt that an X-ray is warranted. An in-home X-ray is made, and the X-ray does show the new onset of a pneumonia before it getting to Tuesday, Wednesday, Thursday. Now, antibiotics are delivered. Michael gets the antibiotics delivered to his home. Now you're going to say, okay, great, this is amazing. Antibiotics are delivered to the home, great. Well, that's not where things end. Like a lot of the presenters said, you know, there's a lot of theory, but we have to think about the practical end of it. So now, you know what else the command center does before the antibiotics comes? The physician prescribes the antibiotics, but physicians aren't perfect, clinicians aren't perfect. We are human beings, and that's okay. So what happens? The physician forgets to check the labs. And it looks like Michael's creatinine clearance and creatinine level is actually elevated. And when he prescribed the Levaquin 500 milligrams, that actually shouldn't have been prescribed. True story, I had a patient who was seen by another provider who was given Levaquin, an antibiotic, at a higher dose than the kidneys can process. That patient ended up needing dialysis. And I'm being honest with you. And it was a very, and actually we put towards the end, the patient declined dialysis and she was put on hospice, or from a little tic-tac tablet called Levaquin. But where we are heading, when the doctor will prescribe this medication, AI will start scanning the labs. And as you know how you scan the allergies, right? The allergies, you'll be able to scan the labs, and we're getting there already. And AI will send a message to Dr. Smith. Dr. Smith, you can't prescribe Levoquin at 500. We suggest that you lower the dose to 250 every other day because of the creatinine clearance. That is where we are going to go. Now, it doesn't end there. You're going to say, well, that's great. You gave the medication to Michael. And Michael has it right here in his home. He has it. Great. But is he taking it? Because if he doesn't take the medication and you think you prescribed it, are you actually getting the job done? Like I teach my kids all the time and my medical students, in any job, in any situation or objective, you got to get in, you got to get it done, but it's not enough to just getting it done. You have to get it done right. And then you say, you get out. The last G is you get out. So just by sending the prescription to the pharmacy, we're getting it done, but we're not getting it done right. And the way we get it done right is look at this pill cap over here. And there's different variations of monitoring medication adherence. This is just one example. The pill cap is there. Unscrew it, and every time that the patient unscrews it, you know that they've actually unscrewed the bottle. You don't know that they've taken it. Hey, my grandma could fool you. She can open it up and not take the medication, but at least you know that they've opened it. And more of these digital innovations. So as a doctor, Dr. Smith, on day number 2, you get an alert. Cap wasn't even opened. Now a care coordinator can call Michael and say, you got to take those meds or else you'll have sepsis. Now, on top of that, I want to show you something else with Michael. Now, Michael is actually home. He's taking his medications, and he's getting weaker still. How do you know that he's getting weaker? You're not going to know. Well, you can. If you take a look, and I'm going to play this video over here. Oh, let me go back. There you go. There are technologies now that we're going to be using that are non-wearable, non-invasive home monitoring based on IR. And it tracks the location, tracks the posture, tracks the respiration. It recognizes emergencies, various falls, respiratory issues, but more importantly, you don't just want to identify when something happens. You want to be able to predict before it happens. So technologies now are collecting data, the non-wearable, IR-guided data, which are able to say, well, Michael usually sleeps till 8 a.m., and he's been sleeping till 10 a.m. every morning. Michael's speed of walking is usually X, and now it is Y. And so by those predictive data points, one can then just think about and say, wow, let's go in, let's take a look at Michael. Let's not have him turn into a Harry. So a lot of folks say that telemedicine, telehealth. Well, I have to tell you boldly that the word telehealth and telemedicine will disappear. What? Dr. Eric, you're just giving the whole presentation about technology. What do you mean it's going to disappear? Well, I'm not saying telemedicine as an art or a science or is a technology going to disappear. No, I'm saying that the word tele will disappear. Why? Well, let me ask you folks, when you go in the 1980s, 90s, when you went to the bank, you went banking, you needed a check, you needed to pay somebody, you were at the bank. Today, do you telebank? No. Today, your idea of banking has shifted from being in a bank to being inside here. This is your new bank because you're able to do any transaction, anything you need through this. I don't go to the bank. So we don't telebank anymore. There is no telebanking. That is banking. And therefore, medicine is not going to be telemedicine. That, what I'm describing now, is going to just be the normal way of doing medicine. With that being said, what is age tech? Age tech is a term used to describe digital technology that is built around the needs and wants of older adults and those who care for them. Preferably, this is very important, you want to include them in the design process. There's a great book written by the founder of Waze, and it says, focus on the problem, not on the solution. A lot of technologies are being created today with folks in Silicon Valley that are creating them, focusing on some solution that they have. But no. Focus on the problem that we have today. Speak to the actual stakeholders, the patients, the caregivers, the doctors, the nurse practitioners, PAs. What are the problems? And then reverse engineer the solution to that problem. And so it's very important to include the stakeholders in the design process. A lot of folks will say, well, older adults are not going to adapt or use technology. That's not going to happen. That will never work, to borrow from Netflix and Mark Randolph. Well, let's look at the data. Smartphone ownership and social media use among older adults continue to grow. Now, this is from 2021, and I'm sure the data has, from the Pew Research, has increased since there, the numbers. But in 2012, 13% of 65 plus individuals owned a smartphone, 13%. And if you go up to 2021, 61% of 65 plus own a smartphone. Even social media, I'll tell you anecdotally, here it shows 45%. My dad and my mom, my dad's 67, who is like the most technologically non-user friendly individual at all. And as I'm getting older, I'm asking my son, who Dr. Pandya had met, my 18-year-old, how to use stuff, to be honest. That's when I know I'm getting a little old. But my dad, he is like completely, and he has Facebook and he has Instagram and he sends me different snippets. So on top of that, our generation, the 40, the 45, the 50-year-olds are going to move in line to be the next 65-year-olds. And so we cannot run away from this. We need to evolve, and we are evolving. There's been a lot of movement towards the evolution of healthcare from where we had it before. So examples of age tech. Robotic assistance for older adults. We know there's a caregiver shortage. And, having done house calls for so many years, I see how difficult it is, both for family members who are caregivers, and that's where there's burnout, caregiver burnout. For home health aides, there's not enough folks. So what's going to happen? Robotic assistance. Robots will be able to change position every 2 hours for Harry in the hospital or in his home so he doesn't get a decubitus ulcer. We talked about remote patient monitoring and clinical decision support. There are companies out there, and New York State has actually worked with a company that focuses on social isolation in the elderly and leveraging a Alexa type technology robot that engages with the elderly. We have now virtual reality and augmented reality where I can have my grandmother put on VR, AR glasses, and I can load videos from the past and have her interact with an avatar of my grandfather. And she can speak. Now, we'll put aside the ethical components of that if my grandfather's not alive, but just to show you where we can go. Financial technology and aging in place technology, such as we have discussed. Why do Apple, Amazon, and other big tech companies develop products and features for the older population? It's called the $15 trillion longevity economy. Now, I just want to show you something over here as well. Oracle, which in the past never was in the healthcare business. $28 billion deal to buy Cerner, and that was in June 7, 2022. CVS to buy home health giant Signify, taking house calls, home health, pharmacy, technology, and putting it all in the mix. Amazon bought One Medical. Now, having said that, there are many, many companies which are coming to the forefront, but I don't want it to all sound rose and peachy, because there's a lot of hype, and only really people who understand medicine, understand healthcare, like Dr. Pandya, like Dr. Katz, like Dr. Milet, who's been in the field, can know when it's fluff versus something real. So there's a company called Babylon Health. Look at what it says here. Confirms 550 million raised at a 2 billion. Wow. They raised 550 million to expand its AI-based health services. This article is dated August 2nd, 2019. Now, let's fast forward. Click. Digital health company Babylon files for bankruptcy in US and will liquidate. What's the date on that? August 16th or 15th, 2023. You go from raising $550 million, and I've used Babylon Health. Among other things, it's a chat bot. It's a digital AI-based chat bot that gives suggestions, recommendations, and you talk to it and it pulls from sources. But 550 million, and now no more. Bankruptcy. And the reason I say this is that I advocate that we need to have more healthcare providers involved in the development, in the involvement with health insurance companies, folks who are in the trenches, folks who are on the ground, folks who do speak to grandmothers and grandpas on a daily basis, because that's where the real data comes from and the real heart and soul of what we do. Now, let's see, next. And I'll leave 5 minutes for questions, but I like this slide a lot. I like Steve Jobs as an innovator, of course. He's changed the way we do a lot of things. And he said something very, very beautiful that I tell my medical students, I tell my kids. And he said this in a graduation address that he gave. And he said, your time is limited. Don't waste it living someone else's life. Don't be trapped by dogma, which is living with the results of other people's thinking. That will never work. We're going to do this because it's always been done that way. Don't let the noise of others' opinions drown out your inner voice. And most important, have the courage to follow your heart and intuition, for they somehow already know what you truly want to become. Everything else is secondary. And so again, I really have to tell you, I am blessed and honored to have the ability. Thank you to Dr. Sweta, Dr. Pandya, and the whole team for giving me the opportunity to speak today. And I'm happy to take any questions from this well-respected audience.
Great. Thank you so much, Dr. Ilyayev. We're now going to begin answering the questions that were submitted during today's presentation. And just as a reminder, you can still submit questions through the questions pane in your attendee control panel. And it looks like we have a number of questions already. Our first question is, what are your thoughts about use of AI in medicine? How can we best evolve with the addition of AI to all fields, including healthcare or medicine, to avoid dissolving?
I do believe very firmly that AI will play a significant part in medicine. I believe that certain sections of medicine will be augmented, certain will be replaced. For example, dermatology, taking a picture of a lesion will get more and more accurate and precise, where you may not really need a dermatologist per se to diagnose what you have. AI will do it. And we have studies, actually. I remember listening to the CEO of Mount Sinai speak maybe 8-9 years ago, and they were already doing this with x-rays, where digital reading of radiology, AI was able to give a better read than a radiologist. And so I do believe that. At the same time, though, I feel that there will need to be checks and balances, because as we see with ChatGPT and other things, it does a great job at what is often called hallucinating. It gives you these answers and you think, wow, this sounds right. But when you actually look at it, it doesn't exist. The source, it doesn't make sense. And that's where I think the Babylon Healths and other of the world, it's going to take some training to do that. But rest assured, we will get there, where AI will have a significant impact on healthcare.
Thank you so much for your response. Our next question is, how are digital technologies improving treatment in heart diseases among older adults?
In which specific diseases? I missed that.
Heart diseases.
Heart disease, so cardiac, big time. Digital technologies have a significant impact. So I'll give you an example. Using remote patient monitoring. You have somebody who is home, they have congestive heart failure. And that individual tends to drink a lot of fluids, not be compliant with their diuretics, love that salty fish. And it gets to a point where the meter goes and it's too late. They have fluid in their lungs and now they need to go to the hospital, just like Harry. Well, digital technologies now are able to remotely monitor the weight, monitor the ins and outs, believe it or not. There are in and outs that can be monitored digitally through remote patient monitoring. And the second you see that the weight is gaining, that's a phone call. That's a prevention of a hospitalization. Medicine will be command centers where all of the data piles in both human beings and clinical decision AI takes the preventive data that comes in and prevents someone from getting sick. So yes, a long-winded answer, but cardiac health is greatly going to be impacted. And we're doing it now. This is happening already with CHF.
Perfect. Thank you so much. Our next question is, what elements of the described technologies exist? And can the tech distinguish movement of and vitals of two individuals who may live together?
Most of the things that I've described today exist. It's like back in the Steve Jobs moment where, you know, mouses existed and screens existed, and someone just put it all together. And so most of it definitely exists. And with AI, it's only getting better and better. And there are technologies which now are working on distinguishing based on breathing patterns. If two individuals are in a room, that they are unique and different, based on heating sensors, that they are unique and different. There's a technology out there which is honestly just fascinating. Back in the day, we needed to measure, for example, blood pressure with a device, right? Well, now there's a technology. It exists today. This is not sci-fi Star Trek, although I love Star Trek, where you can look at a screen like this and it will tell you what your heart rate is, what your blood pressure is, and what your pulse ox is. And now it's getting more and more accurately and accurate and accurate and accurate. It's like back in the day, if you remember, we used to think like checking our blood sugar, and Dr. Pandya can appreciate this. And I'm sure when the Dexcoms came out in the world, it was like a wow moment, because imagine pricking yourself every day, 3 times a day. And then it went to, don't worry about it. We're just going to put a little Dexcom machine over here, or a Freestyle Libre. That's also going to evolve to, I'm just going to put my finger on a sensor without any blood, and it's going to tell me what my blood sugar is. And there's already a company that is working on that and getting good results. So these technologies do exist.
Perfect. Thank you so much. Our next question, this person said that they really enjoyed the talk and they would like to know, how can PCPs gain more knowledge about age tech and bring this up in clinic visits and patients and their caregivers?
PCPs can get involved by pure interest, and there's a great book out there. It's actually called Age Tech. There's a lot of conferences now. There are podcasts on age tech. And I think it's important for us, we'll talk about the PCP level of getting involved. So there's podcasts, there's great books, age tech. There's different programs out there. I know NSU has an amazing health informatics program, which Dr. Bronsberg and Dr. Ramim is part of. It's phenomenal. But I think it starts from here, and I'm actually at NSU at the Innovation Center. It starts in the schools and the colleges and the medical schools of shifting the way we think of the paradigm of medicine, moving away from the blockbuster and teaching our students that you don't listen necessarily to a stethoscope just like this anymore. Hi, Mr. Smith, can you take a deep breath? But this is the new stethoscope. Here, you put it on, it's in the patient's home, and you listen to them remotely, and these students, the next generation of physicians and leaders, can be taught in universities and schools about the next generation of healthcare.
Perfect. Thank you for your response. I think we have time for one more question. And that question is, what proportion of Medicare spending is accounted for by fraudulent practices?
It's a very good question, actually. I don't know the exact data or the number, but it's a great question. And I'd like to say that, I'm not going to say the majority or the significant, but there is a large portion of, unfortunately, fraud happening within the Medicare population. There's about 65 million people on Medicare, 5 million here in the state of Florida. About 48 or 47% are on Medicare Advantage plans, and the rest are on fee-for-service Medicare. That's beginning to shift. And I think as the incentives are changing, right? So before, in the fee-for-service model, think about this, in the fee-for-service model, I am incentivized to see you more. I'm incentivized to bill more. As we shift from the fee-for-service model, and we're shifting aggressively to the value-based model or the at-risk model, what's going to happen is fraud in one sense will decrease. In which sense? It's going to decrease in that I'm not incentivized to bill a lot now. I'm incentivized now to actually spend less money, because the less that I spend, the more that I keep. But remember, it's a pendulum. So on one end, I'm billing. But think about the value-based model. If I'm a doctor and Mr. Smith comes to me and I say, Mr. Smith, your back hurts? You don't really need an MRI. Why? Because now I'm thinking, if I get that MRI and those tests, whose pocket is it coming out of? The practitioner, the value-based model, the at-risk model. And so that's another form of fraud that will happen. It's going to be a completely different type of fraud, where now clinicians are not all clinicians, I'm just saying, where the incentives go, are not as incentivized to do the proper testing because it's coming out of their pocket. And so there needs to be, I'll finish with this. Maimonides, the Rambam, was a rabbi, and he was also a great physician. In fact, Maimonides has a lot of hospitals, and he always said that in life, never be too much to the right and never be too much to the left in anything. Don't overeat, don't undereat. Don't overexercise, don't underexercise. Always be in the middle. And I feel that same thing with fee-for-service and value-based and risk and fraud. If you're in the middle, if your incentives are aligned in the middle, meaning with the patient, then you'll be okay. Thank you for that wonderful question, for this wonderful ability to speak. Again, Dr. Pandya, take off my hat to all of the years of service that you have provided, and really look up to you and all of the speakers here today. Thank you.
Thanks so much, Dr. Yeah, this was a really exciting presentation, and we hope to continue working with you in the future. I think what you've really also brought home to us is we have to be aware of doing the right thing for patients. And certainly by the use of technology, by the use of good clinical care, clinical wisdom, be on site when it dictates, but we need to be able to do the right thing. And
Thank you.
thanks so much for your talk. Now, participants, we have a lunch break till 1:30 p.m. and we'll see you then.
To welcome back Dr. Nashira Pandya. As you learned earlier, Dr. Pandya is professor and chair of the Geriatrics Department at Nova Southeastern University, and the project director of the Geriatric Workforce Enhancement Program at the Kiran Patel College of Osteopathic Medicine. Please welcome Dr. Pandya, who will function as moderator for our expert panel. Nashira?
Thank you. Hopefully everybody can hear me. I'm going to introduce our panel, and my great pleasure to introduce Dr. Alice Bonner, who I've worked with over many years in different capacities. And Dr. Alice Bonner has been a nurse practitioner for 30 years. She's currently senior advisor for aging at the Institute for Healthcare Improvement and the chair of the Moving Forward Nursing Home Quality Coalition. She's adjunct faculty at the Johns Hopkins University School of Nursing and received her AB degree from Cornell University, a BSN from Columbia University, an MSN from the University of Massachusetts Lowell, and a PhD from the University of Massachusetts Graduate School of Nursing. Between 2015 to 2019, she served as secretary of the Executive Office of Elder Affairs for the Commonwealth of Massachusetts. And from 2011 to 2013, Dr. Bonner served as the director of nursing homes in the Centers for Medicare and Medicaid Services in Baltimore. Her research interests include home and community-based programs, nursing home quality, and nursing workforce development. So welcome, Dr. Bonner. And I'm now going to introduce her co-panelist, Isaac Longobardi, who is a recent graduate of Harvard College. Hi, Isaac. How are you? He currently serves as director of the Moving Forward Quality Coalition. So Dr. Bonner and Isaac Longobardi come as a pair, always, right? And that's what they've told me. Previously, he worked as program coordinator for the Hebrew Senior Life Volunteer Youth and Community Engagement Department, while piloting multi-generational living at Center Communities of Brookline, one of the Hebrew Senior Life's independent living communities. Our panelists will talk for about 30 to 35 minutes and will then answer questions. And I'll join you at the question time. So please welcome our first speaker, Isaac Longobardi, who will begin the panel presentation. Go ahead, Isaac.
Thank you. Thank you, Dr. Pandya. So we will provide a brief overview of the Moving Forward Nursing Home Quality Coalition, and then we'll dive into just a few of our action plans, and we'll explain what those action plans are in a little bit. But before, next slide, please. And so you can see that here, and next slide, please. But before we kind of jump into those more detailed questions, we wanted to pose a question to you guys, and that's, what's one thing you would change to improve older adults' experience in nursing homes? I know many of you do not work directly with older adults living in nursing homes, but you probably work with older adults who go in and out of nursing homes, or who have been to nursing homes, or maybe thinking about nursing homes at some point. And curious, sort of from your observations, however rich, what's one thing you would improve? And maybe, I don't know if we can see the chat, Claire, but it'd be great if we could see some of those responses.
I don't think they can, but Dr. Pandya is following along with us, so she can read those responses at any point that she wants to jump in, or at the end. But I just want to echo what Isaac said, that, you know, whether you work in public health or a health system or the community, it's all interconnected. And part of our point today is about nursing homes being leaders in communities. So back to you, Isaac.
So maybe take some time to think about this as we get started, and would love to hear those comments as we go along. Next slide, please. So from us, I just would like to share 3 ideas we've heard from residents, and this is important to us because since the beginning of our coalition, which launched a year ago, and I'll share that story in a second, we knew including residents in all of the conversations we were having was vital. We wanted residents to help us prioritize what we were focused on. We wanted them to help us figure out how to tackle those issues directly, and we wanted to make sure they were part of the solutions as we worked on them. So I just want to share from those conversations 3 really, I thought grounded in practical ideas that residents had posed about improving nursing home quality from their experience. So residents suggested to us that they thought care planning, scheduling could be more inclusive. They thought more active and person-centered roommate matching systems would be incredibly beneficial to their quality of life. And they wanted a more formal system to advocate for one another, not just themselves individually. So it speaks to these suggestions speak to some of the smaller things that we can do to improve quality of life in nursing homes. Some of the low-hanging fruit with really big impacts. So, a question back to you guys is, if you are working in a nursing home, could your nursing home take on just one of these 3 ideas from residents? Okay, so rewinding back to July 2022 or before that, next slide, please. I want to give some context for, what is the Moving Forward Coalition, and it began with a report that some of you may or may not have heard about. The National Academies of Science, Engineering, and Medicine released a report in April 2022 highlighting the challenges that the nursing home system faced and faces still. It was built, I think, it was really launched in recognition of the COVID-19 pandemic and how terrible that was in nursing homes, but it went deeper than that. It's not a report about COVID or exclusively about COVID. It's about everything that underlies the challenges so many of us, lived into during COVID in nursing homes. And we hold up this sentence a lot. It really speaks to sort of the overarching conclusion of the report, which is pretty strong. The way the U.S. finances, delivers, and regulates care in nursing home settings is ineffective, inefficient, fragmented, and unsustainable. All big adjectives. This report was financed in large part by the John A. Hartford Foundation, and when it was published, all 605 pages, they didn't want it to sit on a shelf, and so they funded the Moving Forward Coalition, which is us, launched in July 2022 to take the recommendations from this report and try to move some of them into action as quickly as possible, and that's really what we're doing. So next slide, please. And I'm even going to say next slide again because I think I went over this. Next slide again, Claire. So our vision and mission really came from the urgency of the report and the fundamental nature of what it wanted to tackle in nursing home quality of life and care. So our vision is that every nursing home will be a community in which lives are nurtured, residents are empowered, and where people want to work. And our mission is that we will make vital changes in policy and practice through the power of bringing diverse voices together now. Next slide, please. So we began that mission with haste, and we've divided our work over this 2 years of funding into 4 phases. Next slide, please. The first phase was we convened this diverse coalition. We set up 7 working committees, 1 for each topic from the NASEM report. So those included things like health information technology, financing, workforce, person-centered care, quality assurance. And each of the committees, we really wanted to make sure it represented all the voices at the table, or all the voices that needed to be at the table. So this is a little graphic. It's fairly old now. Our membership changes as we sort of grow and try to include more folks, but we included direct care staff, including CNAs. We included residents in our committees, folks who are managing and leading nursing homes as administrators, lots of experts, professional association staff and leaders, state agency staff, and some former surveyors, a really robust and diverse group to come together and think about what are some consensus pathways forward. Next slide, please. So the first thing we had them do in the fall was prioritize recommendations from the NACEM report under their goal heading. So if they were financing, they were meant to prioritize the one to two recommendations from the set of 3 to 5 of them that were under that goal. And we asked them to do so within the rubric of the 4 values you see on the screen: equity, sustainability, feasibility, and collaboration. So what recommendation did they think would have an equitable, sustainable, feasible impact in a way that could be collaborative? And they, over the course of the fall, they thought through those issues together, and they did just that. And you can read their priority statements, which came out in December, online on our website. Next slide, please. Over the course of the spring, we asked them to then take each recommendation that they selected and turn it into an action plan, which is to say we asked them to answer these 3 questions. What can the coalition accomplish in 1 to 2 years to achieve that recommendation? What do we need to do it? And what are the specific steps along the way? So they developed those action plans. They're also on our website. They really reflect where we are in the work now. We really did, I think it's important to emphasize, lean into the idea that this coalition, this group of people together, could achieve these goals in the short term. And so we challenged these folks to think in that practical short-term way. Next slide, please. And on July 18th, we published or posted our 9 action plans that came out of these planning discussions. You can see them sort of, these are the titles of them. They're obviously very informal titles, but they speak to kind of the scope of the breadth of the different issues we were working on. We posted them and are now moving into the process of implementing them. So I'll just share them briefly. I'll read those titles. Improving CNA compensation with Medicaid quality incentive payment programs, expanding CNA career pathways, enhancing surveyor training on person-centered care, designing a targeted nursing home recertification survey, increasing ownership data transparency and accountability, financing household models and physical plan improvements, developing a nursing home health IT readiness guide, strengthening resident councils, and addressing residents' goals, preferences, and priorities. So at this point, we'll now dive into just a few of these. Our committees are hard at work getting these things done. But next slide, please. I just want to provide just a little more context for you in terms of the diversity and the engagement of our coalition. As we've built these committees, we've also been building a much larger footprint. So to date, over 1,000 people have signed up to get involved in the coalition's work in one form or another. And these organizations, plus a few more since we developed this slide, have given their support to the work of the coalition. And we're really proud of just how many perspectives these organizations and those over 1,000 individuals represent. Next slide, please. Along the way, and I know Alice will get into this more deeply, we've also engaged a number of policy-making agencies and organizations, both at the federal and state levels. And that's been a continuous process of building really strong relationships that we're excited to continue to build into the second year of our work. Next slide, and Alice, I think it's your turn.
Okay, great. Well, before we dive into one of the action plans, I just wanted to feedback some of the responses that people chatted in about the question, if you could only do one thing with nursing homes, what would it be to improve quality? Someone said timely medical care. Someone said focus more on what the person can do, not what they can't do. And someone else said encourage activities and reorientation, especially in people with cognitive challenges. So I think it's interesting that, of all the things people could have said, you all said, everybody who responded so far said something that was really about the person living in the nursing home. And that's one of the themes that I hope you all take back from what we're trying to do as the Moving Forward Coalition. Is we're really trying to keep the voice of nursing home residents front and center, and I'll talk more about that in a few minutes. So next slide. So we're going to talk for a moment about one of the action plans that is focused on workforce and staffing. This is particularly timely. If you follow the news, you may have seen that just 1 week ago on September 1st, CMS released a notice of proposed rulemaking, so a proposed new set of requirements around nursing home staffing. We're happy to provide the link to the Federal Register and the White House fact sheet on that, but this is something that is a very hot topic right now. You probably know that, but very important to stay in tune with what's happening. There is a 60-day comment period, by the way, so it's important because if this is important to you and you think we can make a difference, you can send in comments for 60 days. So our action plan is actually very, very focused on direct care workers, certified nursing assistants or CNAs in nursing homes. And this action plan that we're talking about today says that, you know, once people become a CNA, there need to be ladders or lattices, pathways that they can follow to be able to advance their career as a CNA. We know some CNAs want to go on and become a nurse or a radiologist or some other career, but there's a lot of CNAs that have told us they want to advance within being a CNA and staying in that role. Next slide. So this slide's kind of busy, but if you just look at the teal titles above the buttons here, there's a couple of different ways that we can approach this, and the action plan is very comprehensive and it addresses all of these things. There's the issue of recruitment, and that's the first button here. How do you get trained to become a CNA? So that's a recruitment or getting people into the pipeline approach. Then there's also, once you are a CNA, what about retention? We have a big issue with retention in nursing homes. Lots of staff have left and lots of staff leave all the time. It's a big, big challenge, lots of turnover. So you can, you know, look at ways to advance your career once you are a CNA, and there's a variety of ways you can do that without an apprenticeship. And then where you see the green arrow, that's about apprenticeship programs, registered apprenticeship programs, specifically for CNAs that want to stay, but want to advance their career as a CNA. And again, timely issue, literally 3 hours ago, Isaac and I were on a call with a bunch of people in the state of Florida talking about workforce and talking about these apprenticeship opportunities. So we can say more about that. Next slide. So there is something called the Federal Office of Apprenticeships, and this is one of their slides. And this is, again, it's part of the federal government, and they work with the Department of Labor, and they have lots of materials and lots of ideas and approaches and people and resources that they can share. They don't take over everything, they don't solve every problem, but there's a lot of support that can really come from the Federal Office of Apprenticeships. One of the things Isaac and I and our whole team have learned is that a lot of states don't really know about this office. They don't know it exists, or they don't have a connection with them yet. And so what we're finding through our state-by-state work is we have opportunities here just to share information. So more nursing homes and more providers and medical directors and primary care providers such as yourselves can get this information and work together. Next slide. So this is another slide from the Federal Office of Apprenticeships. And again, it's showing you that some states work directly with the federal office, and that's the sort of teal or aqua states. And the dark blue states are ones that have a specific state apprenticeship agency. So look at Florida, you have your own state apprenticeship agency in your state. That means if you don't already know that person, we could connect you with that person. You could talk to the director of nursing or a licensed nursing home administrator you work with, and we can put you in touch. And that's turned out to be really valuable for individual nursing homes who didn't know how to access these programs or some of the supports, including financial supports. Again, limited, but they are there. Next slide. The other thing is these are programs that do depend on employers. So they depend on the nursing home. You know, the federal office or the state office of apprenticeships, they don't start up these programs on their own. They respond when a nursing home says, we want to do this, we can do this, help us to get started. So the role of the nursing home is really important here. And again, a good opportunity for medical directors or primary care folks like any of us to say, hey, have you looked into this? Would you consider it? Is it something that would help you build the workforce? Because we know from talking to people across states, workforce is an issue almost everywhere. Next slide. So I already mentioned this. Isaac and I were on a call with our workforce team. We talked to a bunch of organizations in Florida, Leading Age Florida affiliate, AHCA Florida affiliate. We've been in contact with Dr. Chris Kogel. You might know he's at Medicaid and the university, and we're on the phone with you guys today. We work with the QIO, the QIN, et cetera. So more to come on this, but we are active and we really want to be more active in the state of Florida. Next slide. Okay, Isaac, back to you on a different action plan topic.
There we go. Thank you. Sorry. So the next action plan we want to talk about is our work on increasing transparency and accountability of ownership data. Next slide, please. Another pretty hot topic at the federal level with its own set of new rules coming out of CMS. In February, CMS released a proposed rule to require nursing homes to report their related parties, among other things. And in June, CMS released a proposed rule to share ownership information on Care Compare, which many of you may know is a site open to the public to help them filter and understand different nursing homes. So that data kind of working to not only acquire the data better from nursing homes, but then also share it back with communities and consumers more readily. So both very important things. But what our committee kind of discovered along the way was that while we're having a lot of these conversations about ownership, transparency, and accountability at the federal level, we're not so much thinking about ownership, transparency, and accountability at the state level. Next slide, please. So before we get into that, I just want to share a few things that as our committee were putting their heads together, they kind of set out some intentions for long-term federal action, what they'd like to see in federal policy in July 2025. So they wanted to see that nursing homes will provide ownership information with supporting documents beyond current self-reporting requirements. And they suggested that the coalition could work with federal agencies to support that. They want to see clear time parameters and penalties for failure to comply with reporting requirements under Section 6101 of the Affordable Care Act. And they want to see auditing of that. They want to see that there would be routine CMS and/or state auditing to verify whether ownership information being reported by nursing homes is complete and accurate. And they wanted to make sure that ownership information will be publicly reported in an accessible manner using easily interpretable terms. Hopefully the Care Compare action is a positive step towards that. Next slide, please. I also wanted to add, many of you may be part of AMDA, or the Society for Post-Acute and Long-Term Care Medicine, and it's a great example of clinicians taking action on nursing home transparency. AMDA has worked really tirelessly on this HR 177, which is an act to amend the Social Security Act to ensure that nursing facilities report information on medical directors of those facilities. And I think it's just such an important acknowledgement that each of us can play a role in creating accountability and transparency in our community at the place where we're coming from. So just a big kudos to the folks at AMDA who are a very important part of our coalition. And then next slide, please. And so back to the states, we really wanted to see what was going on at state level, because the truth is each state looks at ownership data a little bit differently. They collect different things, they define terms differently, they share information across different state agencies to varying extents, sometimes not at all. When they're going through the licensure process, they may or may not look at data from other states. They may have very limited criteria for whether new owners can take over a nursing home. They may have very extensive criteria. It's a completely varied scene, and it's very unclear what each state looks like. So our group really wanted to do a deep investigation into that. So they're going through with great diligence, looking at each state to kind of document and what ownership data, transparency, and accountability looks like. Here are just 6 of the questions they're asking. They're really asking many more, and it's been a really tremendous, from my perspective, tremendous example of how coalitions should work. Each person taking a state, reaching out to their contacts, doing research, speaking to folks in state agencies, in the licensure agency or elsewhere, in a way that is just really remarkable. Next slide, please. Over to you.
All right. So I just want to say, I hope that what you got from Isaac presenting that particular action plan is the interplay, the intersection between being a clinician, being in practice, being someone who does this work every day, either in a nursing home or maybe you work in a hospital or a clinic or home care, but bringing that to the policy space, because you can tell stories and you can tell make the compelling case that other people cannot necessarily make. So we hope that you'll think about your role as an advocate, your role as a policy person. Anybody can do that, and nobody's going to tap you on the shoulder and say, are you going to do it? They're just going to hope that, people like any of you on this call will say, I could do one thing in my practice. I could take 1 hour out of my day, one day out of the month, and really think about some of these policy things. So anyway, to the next action plan, which is about resident councils. And you probably know that it's in the regulation that if any resident in a nursing home would like to have and be part of a resident council, the nursing home must provide the space, they must provide the staff support, etc. And the residents drive the process. The residents decide who gets invited, they decide how often to have the calls, etc. Next slide. One of the things that we found out is we did a lot of interviews with nursing homes, and we had some nursing homes that said, oh yes, we have a great process. Here's how we do it. And they go through from soup to nuts, and it sounds absolutely terrific. And it's consistent with what's in the regulations. And then other nursing homes said to us, we haven't really been doing it that way, but we'd really like to be able to do it better than what we're doing now. So how can you help us? So Dr. Barbara Bowers from the University of Wisconsin, she's emeritus now, she did a lot of interviews with residents around the country, over 90 now. This slide is a little dated, but we brought together probably 90 or so residents. We have a resident, as Isaac said, on our steering committee. And, Metastar was one of the QIOs that also is very interested in hearing the voice of residents. So part of that is this action plan around how can we strengthen resident councils around the country. Next slide. So again, there's a couple of examples here. CalTCM is the California AMDA chapter. You might know them. Dr. Mike Wasserman is now on the AMDA board, and he's very active with CalTCM. Also in Connecticut, Mairead Painter is a wonderful long-term care ombudsman, and she has a statewide group that really does a lot with resident councils. But those are just two examples. We'd love for Florida to be up on our slide too. So, what could Florida do? What would you want to do related to resident councils? And these are some examples of what resident councils can be beyond just getting feedback from residents. The last thing, any of us want, I think, is to have it be a complaint session. That's not what the purpose is. The purpose is to actually hear from residents, have them articulate what matters to them. And I'll tie that back because I'm on the age-friendly health system team at IHI, and I know a lot of you on this call are involved in age-friendly health systems, including age-friendly nursing homes. And so asking people what matters, that's one of the 4 M's in what matters: medications, mentation, and mobility. Anyway, lots of different things that resident councils can do. Next slide. One of the things that the committee has done over the past year is they've done a very thorough literature search, and they've looked through a lot of the scientific studies, but also the great literature, and came up with a number of different guides and resources on how to run a resident council. They liked this one the best by the Kansas group. And so right now we have partnered with 3 nursing homes in different parts of the country. They have this as a draft. They're looking at it, they're evaluating it, and they're sending us feedback to let us know what they think should be changed, what would make it better. Do they like it? Do they not like it? Would they use it, etc. So that's an example of how these committees work. As Isaac said, we do the drafting, we need reviewers, we need experts, we work with nursing homes, we work with advocates, we work with people like all of you. Next slide. So that brings us to discussion and Q&A, and I've been watching the chat, but there may be other questions that Dr. Pandya has for us. So with that, Dr. Pandya, we'll turn it back to you.
Okay, Thank you so much. I'd just like to ask a question myself, and we do have a few other questions we can discuss. I read with interest the CMS proposed rule about staffing, and really as a clinician, I couldn't agree more that we need, RN staffing 24/7. And nursing homes are sometimes like mini hospitals, as we've said for many years. We need more skilled people, but there's such a nursing shortage and also a lack of interest amongst younger trained nurses to work in the nursing home setting. So what ideas do you all have to reconcile this? And there's already a lot of pushback from nursing home owners, administrators about these staffing regulations that have been suggested.
Well, I'll start, and then Isaac can jump in too, because we're both involved with these workforce efforts. First of all, we do not comment on the specific NPRM, so we will not do that. However, the general topic of staffing, I think what's really important, and again, for people to know, so I'm a nurse practitioner, I've worked in nursing homes for 30 years. The importance here is to first decide, how do we calculate the number and types of staff and the roles that are needed in order to take good care of the people who live in nursing homes? That's the first question. And we just have to separate that from, who's in the workforce, do people, come into the pipeline, the recruiting issues. Those are really important issues also, but we have to separate them, because I don't think we can say, because we don't have people right now, that means it's okay to staff at a lower level, right? The first question is, what is the appropriate level of staff and the types of staff? Somebody had, I think, written in earlier some questions about LPNs. What's the relationship between LPN staffing and quality outcomes, as opposed to RN staffing and quality outcomes, or CNA staffing and quality outcomes? Each of those separate categories is important, because those people each have a different type of training and do different tasks with nursing home residents. But I think, your point also gets at something that we have other slides about, which is the image of nursing homes and the image of working as a nurse or a CNA in a nursing home. And if people don't think it's a good career, if they don't think it's a good opportunity, if the wages and salaries are much lower than other settings like hospitals, where it's going to be a fundamental issue, and it's going to be hard to get around that, which I think is your point. So I'd love to hear from other people on the call in terms of how we can get at that. But some of it involves, who else can we get to come together in a state or at the federal level to help to solve these image issues? Right now, the Gerontological Society of America, GSA, some of you are in that organization, they are doing a big reframing aging initiative, and the Frameworks Institute has been doing that for years also. So we do need to get rid of ageism, and we have to reframe what nursing homes are, who works there, who lives there. So Isaac, what else would you add to Dr. Pandya's question?
I think that was a great place to start, and I think from the coalition's perspective and our 2 action plans, the goal is to increase staffing and to keep nursing home staff in place. And so, regardless of how you think you ought to get that at the macro policy level, we know we need to pay nursing home workers more, and we know we need to provide them with more tools to be empowered as staff. And the coalition is really dead set on those things.
Yeah, I agree. I mean, even as a physician, I sometimes felt when I went into long-term care, my colleagues looked down on me, oh, you didn't get to be a cardiologist or something, Well, I sort of feel what I've done is really important, as many clinicians do in long-term care, and we really have an impact. So I think reframing aging, and also trying to work on the ageism amongst healthcare professionals and health profession students. How few of us, we've been tracking our students at the university here, less than 2% have expressed any interest in aging care. So I think that that's really important. I have a question here. What happens to the coalition when funding ends?
Well, we work very hard. Yeah, it's a good question. So our funding right now, the John A. Hartford Foundation funding that Isaac talked about, that goes through the end of June of 2024. We are already, we've already received some additional funding from, like Columbia University and Johns Hopkins School of Nursing and other organizations that have donated much smaller amounts, but still significant in-kind resources. We've already started to reach out and think about larger funding. We have one proposal that we put in for $500,000 grant. So, we're looking at things like that. But I think it's a good question for anyone on this call to answer. Is this an organization that will continue and should continue? Are we doing something that no other organization is doing? Or are there places where these action plans could live with other organizations that can really support them and put in the resources and the time and the effort to actually focus on the work itself, because that's what's really important. So
you can start to seed, projects, but they need to disseminate. They need to move, carry on in a broader fashion. And tied up to that, there's a question about, is assisted living on the coalition's radar? And as clinicians, we look at it as a continuum.
We get that question almost every day, not every week. Oh. Isaac, do you want to take that one?
Yes and no, right? No, in the sense that we're the Nursing Home Quality Coalition, but yes, in the sense that I think we see nursing homes as part of a long-term care system, as so many of you do, probably all of you. So I think assisted living communities are a vital part of that conversation, insofar as we have to think about the transitions of care, and certainly we're doing that very specifically in our conversations on goals, preferences, and priorities, and very specifically in our conversations on health information technology and interoperability. But right now we're all about nursing homes. And
that's what we're funded. That's all we can do right now under our current funding. But I think, to Isaac's point, what's particularly important, and I think the reason why people keep bringing this up, is that, you said this earlier, Dr. Pandya, that, nursing homes, the image of nursing homes is problematic and has been for a long time. What if more and more nursing homes go out of business or decide to close, and there aren't that many beds, and there are more older adults or people with disabilities who would want to live in a residential setting of some sort, or need that kind of residential overall care? More and more assisted living facilities in many states are providing memory care units for people with cognitive challenges, are providing care for individuals who are nursing home level of care. And for people who are fairly new to the field, that means, the state office that evaluates older adults to determine whether or not they're going to pay for nursing home care. They have to meet certain criteria. So more and more people in assisted living would meet the criteria for the nursing home level of care. And that means it's possible that over time, there'll be fewer and fewer nursing homes, and there'll be more assisted livings that have a broader array of services and can support older people for a longer period of time. There's assisted living residences now that will keep people all the way through hospice and end of life care, and they won't transfer them somewhere else. That's not the typical assisted living, but a lot more are doing that. So,
and over the years, we've seen a transition from a social care model to taking more medically complex patients, which behooves the administrators and owners of assisted living facilities to ensure that they have trained nurses who can deal with complex people, who can deal with even a pneumonia patient that can be treated on site, or common infections. So I think the model of assisted living is changing, and I know a lot of work is being done amongst big assisted living groups to ensure that. I have another question here. It seems that the government is constantly trying to squeeze more out of the long-term care sector without increasing the funding pie. What are your thoughts on that?
I think, for those of us who've worked in the long-term sector for a long time, and I'm now talking broadly, whether you're in home care, hospital, assisted living or nursing home. I think there have been challenges with the amount of funding over time. Again, if you look at the compensation for running a nursing home or assisted living and how much people get paid who are the direct care workers, in a lot of places they're not making even a livable wage. Something like between 30 and 50% of direct care workers are on public assistance, either Medicaid or some sort of public assistance. So it's a real issue. There's been a lot written about that. But it's tricky to track the dollars. And I think Isaac can speak to this even more because, you know, the committee he's been working with closely has been really trying to figure out how does a state, you know, track the dollars that come into the nursing home and how much of that funding goes either to salaries and benefits and wages of workers or goes directly to resident care. And it turns out states aren't really able to do that very well. And so that's part of getting the answer to your question has been problematic in terms of the methodology. But Isaac, what else would you say about the sort of compensation or the reimbursement related to long-term care?
I think you're right. And I think we, you know, we're looking at financing pretty holistically right now. We're thinking a lot about, you know, when we want to push nursing homes towards the sorts of communities that we want to live in ourselves, right? More private rooms, more private bathrooms, outdoor space, etc. Right? Like that costs a lot of money. So one of our action plans, which we didn't talk about today, is looking at what those incentives look like. So I think a big coalition area of focus is like, definitely there's need for more funding. How can we target that funding to the sorts of goals we want? So we talked about it with workforce a little bit, and our other workforce action plan is really invested in the incentive payment programs, which is a little more geared towards the way we direct payments. But then there's also questions about revamping and revitalizing the system and the buildings to be more person-centered.
More home-like and be more pervious to the community, where the community goes in and out of those nursing homes. I think that would also change the image and the value of these people who have had such amazing lives, who are now residing, you know, next door to the people who are isolated.
That's a great example of how every person on this call, every one of us, can do one thing that would not be burdensome, and it could be picking up the phone and making one phone call in your town or your city to one legislator or somebody on your, you know, board of selectmen or the mayor, and, you know, just raise your voice to say, you know, have you visited a nursing home? Is there something we can do? Can we bring some people to talk to you about nursing homes? And, you know, half an hour is plenty of time to, you know, lay out one issue that you really want to talk about. What's happening in the school system in the town where you are? Does the superintendent or do the principals know anything about students coming and volunteering in nursing homes? Some towns, they have a fantastic program. It can be done. Other towns, not so much. So just think about something like that. One phone call, one quick letter or quick email. Everything matters. Every small step matters and does make a difference. And when you start to get a lot of people together doing it, so what if you got, you know, 10 people in your town to do it, and then more people wanted to do it, and then you got 20 people, and then 30. It's that kind of thing. It's grassroots. It's good old-fashioned public health. That's what this is. And nursing homes need to really be visible as a part of public health, and very often they're not thought about. So
the invisible, shrouded buildings, you know. That's really so important. Just another quick question. How do action plans lend themselves to work at the local level? And how can geriatric providers do their part? I know you covered that to some extent, but action plans going to work at a local level.
So a number of local levels, I think, sort of we're most excited right now about some of our state work. We've launched 2 state teams, one in Pennsylvania and one in Michigan, to decide on one action plan they want to take up together and realize it in their state community. And those have just been such wonderfully generative groups of energy and excitement and activity. And they've really only been meeting for the summer. So those state teams are something. And we've talked to folks in a number of other states that are doing similar things, even if not, officially part of the Moving Forward Coalition, including Ohio and South Dakota and Colorado and elsewhere. So really exciting work at the state level. And to that end, a lot of our action plans speak to pilot testing something in just one state. So related to our Michigan work, one of our action plans is about person-centered care training for surveyors. The thesis of the group is that surveyors actually don't know what to look for when it comes to person-centered care. They don't know if they're seeing it or not seeing it when they go into facilities. And that more to the point, they need to be part of the person-centered care conversation with clinicians and others in a direct way. And we've just gotten word that we'll get to work with the Michigan State Survey Office to lead some trainings there over the course of the year with their surveyors, which we're incredibly excited about. So a lot of state pilot testing. A lot of our action plans have piloting and feedback processes that hopefully will engage nursing homes and their clinical administrative teams. And so those include our work on resident councils, our work on goals, preferences, and priorities, and our work on health information technology maturity, among some other things. And if as you're looking at our action plans, you're like, oh, I'd really love to do that in my nursing home, or I have some thoughts about why that's not going to work in my nursing home and how you can make it work in my nursing home, we're really all ears and hope you'll reach out to us. Alice, other thoughts on that?
From my experience, go ahead, Alice.
I was going to add, on the slide that's still on your screen, you can click on that QR code if you'd like, and you can just, check out the website. If it appeals to you and you think this seems like something I'd really like to get more involved in, just click on the Get Connected button if you want, and you can send your email and who you are, and we can reach back out to you if you'd like. Otherwise, you'll get our newsletters and things like that. So I would say those things. And Dr. Pandya, there was a question that Tiffany posed about whether or not we have templates. Isaac, whether you or Sumeri have templates about, if someone wanted to reach out to a legislator and talk about an issue, is that something that do we have that posted on the website? Or I know we can provide it, but.
We don't have that posted on our website currently, but it's a great idea.
Mm-hmm. Yeah, and we can absolutely work with people who want to do that. It is a great idea, and we want people to have easy to use resources, and we can certainly do that. Or you could work with us and help us develop it. So we love co-designing things, just for the record. So.
Yeah, I think several organizations have templates like that where you can, very easily click and reach your legislator, whatever party, and type in your message. Because I think what you said, Dr. Barnum, the value of experience and stories, because some of our legislators really don't know what's going on other than the official reporting that they see. I personally think the stories, and even we need to kind of change the concept of aging per se, and also aging in the institutional setting. We need to change the perception of the public.
Absolutely.
That's not necessarily bad places. These are actually places where some people have worked for decades very hard for very little money because they believe in what they're doing.
Right. And we also, again, a lot of what we talk about or try to talk about is how do we raise all boats here? How do we make this, how do we make all nursing homes, or as many nursing homes as we can, positive places where people want to work? That's part of our vision statement. And I do think that's really important. So, again, it's that reframing aging, as you said, and, we have to acknowledge that, there's really good nursing homes, there's kind of middle of the road nursing homes, and there's some poor performing nursing homes that aren't in compliance, for example, and aren't mission driven. And so I think we have to be honest about that and say, okay, how can we do better? Wherever we are now, how can we do better? And maybe people on this call are working in a, really wonderful 5-star high performing nursing home. And maybe, there's some things that are working really well and other things you'd like to see fixed or improved. And you can lead on that. You can, you can go to the nursing home and say, here's the amount of time I have. It's not unlimited. Here's my expertise. I really want to help make a difference. And I think you'll find a lot of people working in the nursing homes are going to be really, really grateful for that. You know, the role of medical directors has really grown tremendously through AMDA and other organizations. And it's a great opportunity to really, you know, share what you can bring as a leader.
Following through that, Dr. Katz had a presentation earlier, you know, on improving nursing home care and raising the bar. But he noted that in the NASM report, there are only a couple of pages devoted to physician, you know, issues. I'm just wondering whether that's something that should be expanded, because people need to realize that this is not just a place where people are aging and not always in comfort and not always in good health. I mean, there are some people who are on ventilators, you know, there's some people who have gastrostomy tubes, you know, they're quadriplegic. So these are complex places. And I often feel over the years that to look at the amazing care that's actually provided to these people who have survived years in the nursing home setting, I don't feel any hospital could do that. And we have patients who go 3 days to a hospital and they come back, you know, completely debilitated with bed sores and in much worse state than we sent them out. So I think we need to maybe think more deeply about the complexity of the care and what needs to be. I know nursing homes are required to assess annually their capabilities, and we're getting deeper into infection control and antibiotic stewardship and better medication management. But I think we need to recognize the heterogeneity of the patients that we care for, the heterogeneity of facilities. Facilities in poorer zip codes don't perform well. Well, there's money behind that too, or lack of. So I know I've kind of talked about a lot of different ideas, but you know, some of us in the clinical setting in the trenches feel strongly about this.
Well, I think that validates our point earlier about it is the clinicians who are in the trenches. It is those of you, it includes those of you who are, you know, doing this in the nursing homes or other settings every day. Your voice matters. That's the voice that needs to come through, and no one else is going to do it. So it's, you know, just pick up the phone, just start. Don't wait for someone to say, oh, it's important that you do policy, even though I said that earlier, but it is important. And so, you know, just take it upon yourself, talk to colleagues, talk to other family members, you know, talk to Ian Cordes or the team and figure out what you can, you know, put on the agenda for some of the meetings that are coming up. Pick one, I know you already have this, but, you know, what's the one policy thing that FAMDA is working on right now? Can you get behind that? Or do you want to propose something else that's really important to you? All of these things really do matter, and that's what's going to lead to meaningful change. It isn't going to be us starting up a coalition. As much as I would love for it to be, you know, really meaningful and sustainable, and I hope it will be, it's really built on the backs of people like all of you on this call and the people who are doing the work in the coalition. It's not just me and Isaac and Sumere, the three of us, it's people, 130 people all over the country who are committee members, work group leaders, etc. So, so what you do really does, you know, it really does matter.
Okay. I think, do either of you have any parting last thoughts? You've given us a lot to think about, and we're at 3:15, 3:16, so I was just going to wrap up if there weren't any questions from the participants.
Go ahead, Isaac, you wrap us up.
Well, we hope to hear from you. I hope that I see a bunch of emails from Florida coming in the next couple of days, and I think those words that you shared, Alice, about the role of clinicians are so vital, and the coalition is so blessed to have so many clinician voices in it who are so dedicated to quality improvement. I also think that clinicians are the people who family members and nursing home residents see every day, and I think they make such a powerful impression on people's experience of nursing homes and their ability to see nursing homes as vital parts of their community. So I think even the small actions of everyday care in nursing homes and kindness are just so valuable from clinicians in terms of changing that image. So it's the big stuff and the small stuff, and just really grateful to get to talk to you guys.
And I will just say I will be in Tampa at the GSA conference in November. And I'm happy to meet with anybody who wants to follow up on this. So let Dr. Pandya know, and we'll be glad to put something together. So thank you all very much for listening, and thanks for all you do every day.
Okay, that was great. Thank you so much, both of you. Clara, you can wrap us up.
Okay, well, thank you everyone for attending today's online symposium, the 4th Annual Re-envisioning Elder Care Conference. All attendees will receive a follow-up email within 1 day that will include a link to a conference evaluation survey. For those of you who have paid for continuing education credits, this survey will also request required documentation for CE reporting purposes. PowerPoint presentations, as well as a recording of this webinar, will be posted on the FSU College of Medicine's REACH website and YouTube channel, and Nova Southeastern University's SF GWEP's main webpage and YouTube channel. And with that, I will pass it over to Dr. Katz for his final closing remarks. Thank you.
Thank you, Clara. I want to thank all of our attendees, speakers, and sponsors for another very successful conference. Of course, I also want to thank the members of our planning committee, including Oksana Schneider, Sweta Terrari, Dr. Pandya, and a special thank you to my colleague at FSU, Tiffany Holcomb, who has again helped organize much of today's offerings. I also want to thank Clara Robinson from GoToWebinars, who again guided us seamlessly through today's conference. So thank you again, Clara. And today, just to summarize what we've heard talks ranging from specific clinical issues such as antibiotic prescribing, dementia, dizziness, to issues focused on nursing home workforce, and as well as the promise of technologic innovation in the care of older adults. And finally, as we've just heard, Dr. Bonner and Isaac Longobardi reviewed the Moving Forward Coalition and its most recent action plans related to improving nursing home care. I think all in all, this has been an incredibly successful day, incredibly informative. And I want to thank everyone for spending most of their day with us today. And we look forward, pending successful funding for the next GWEP applications. We hope to be seeing you next year for another conference. Everyone have a great weekend, and thank you again.